ये सब तुम्हारा करम है आका, के बात अब नहीं हुई है। इसलिए का है आरज़ू का, बशीर कहिए नज़ीर है, सिराज हीर कहिए। जो सर बसर है कलाम रबी, वो मेरे की जिंदगी है। वो इसलिए का है आरज़ू का, तजल्लियों के कफी मुरादे कल्बे खलील तुम हो। खुदा की रोशनी दलील तुम हो। ये सब तुम्हारी ही रोशनी है। सलीका है आरज़ू का, ना बंदगी मेरी बंदगी है। ये सब तुम्हारा करम है आपका, के बात अब तक बनी हुई है। इसलिए का है आरज़ू का।
Jazakallah. Now, to formally start the inauguration, I would request Professor Dr. Amir Ali Chaudhry, Head Department of Optometry and Ophthalmology, Medina Teaching Hospital, and the University of Faisalabad, to please give his inaugural address. Thank you, sir.
Bismillahirrahmanirrahim. Honorable Professor Syed Asad Aslam, our chief guest, Professor Amanullah, Rector, University of Faisalabad, Professor Suhail Sarwar from Lahore, Professor James Wolfshan, Dean, University of Austin, Professor Akram Malik, Principal, University Medical and Dental College, Professor Akmal Hussain, our Chief Neurosurgeon, Professor Nasser Chaudhry, our old-time friend and colleague and very young professor from Mayo Hospital, my colleagues, all the delegates, Assalamu alaikum. So it gives me immense pleasure to welcome you all to this third International Myopia Conference. It's an honor to host such a distinguished gathering of ophthalmologists and optometrists who are dedicated to tackling the visual health challenges of our time, and that is myopia. First and foremost, I extend my sincere gratitude to each one of you for taking the time to join us at this important event. Presence of friends who have traveled here reflects a commitment to advancing our understanding and management of myopia. I would also like to express my deepest appreciation to the organizing committee and our colleagues from University of Faisalabad and University Medical and Dental College who have worked tirelessly to bring this conference to life. As we all know, myopia is a major ocular problem affecting millions of children worldwide. The increasing prevalence in children and young adults calls for urgent evidence-based interventions. As far as I remember, when we were students, there used to be at the most one student in class who used to wear glasses. Now you go to any school, you will see numerous students wearing glasses or myopics. So it was considered that it's a genetically based disease and it's pre-programmed genetically. However, nowadays it has been realized that the environment and environmental factors and modifiable environment factors, they also play a role in the progression of myopia. So this conference serves as a platform for the exchange of ideas, presentation of research, and the discussion about solutions. Optometrists, our optometrists, they play a crucial role in the early detection, prevention, and management of myopia. And the advancements we continue to witness in treatment strategies, including myopia control lenses, pharmaceutical interventions, and behavioral modifications. Then our ophthalmology department is busy in surgical treatment, including photorefractive surgery, intraocular contact lenses, and clear lens extractions. That is the surgical treatments of myopia. Moreover, our department is committed to research, innovation, and collaboration. Our ongoing projects in myopia management and our partnerships with other institutions reflect our dedication to addressing this growing problem. However, we recognize that no single institution or country can tackle this issue alone. It is through collaboration, knowledge sharing, and continuous research that we can make meaningful progress. With that, I warmly welcome to all of you. May this conference be a productive, enlightening, and inspiring experience for each of us. Let us embrace this opportunity to collaborate, innovate, and make a lasting impact in the fight against myopia. Thank you very much. If I there are there are many other senior colleagues who have just joined us. I can see Dr. Hanif Saab from Jung. He has just joined us, and my other colleagues from our institution and other institutions. Thank you.
Thank you so much, sir. We will now formally begin with the first scientific session. It is my great honor to introduce the chairperson for the first scientific session. Professor Dr. Asad Aslam Khan is the most renowned and arguably the most well-published ophthalmologist in Pakistan. Sir Sitara Imtiaz, he is currently WHO Coordinator for Prevention and Control of Blindness. He has also served as Pro Vice Chancellor, King Edward Medical University. He has served on many portfolios related to myopia, and we are very, very honored to have you here with us today, sir. Kindly come on stage for your seat. Thank you, sir. I would request Professor Dr. Amanullah Malik, our worthy rector, the University of Faisalabad, a very eminent scientist and well-known personality in the field of research, to please join Professor Aslam Khan on stage, sir. Thank you. Our co-chair for today's session is a very honorable and well-renowned ophthalmologist with a lot of work in the field of myopia. Professor Dr. Suhail Sarwar has a prolific work experience with myopia. He is consultant ophthalmologist, King Edward Medical University. Please, sir, kindly join us on stage. Thank you. Starting with the first scientific session, our first speaker, Professor Dr. James Wolfson, is a very well-renowned optometrist around the world. He is currently serving as the Dean, Department of Optometry at Aston University, UK. Professor James brings along with him a wealth of experience as well as knowledge. I would request Professor James to kindly come on stage and enlighten us with his keynote. Thank you, sir.
Not the right presentation. It's not the right now. It's not the right. Thank you so much for inviting me to speak with you today. I'm truly honoured to be at this fantastic conference and to meet you all. And I have very much enjoyed my first time in Pakistan. So I'm going to be speaking to you about global trends in myopia management and the attitudes of eye care practitioners and the strategies that they're adopting. I'm the Chief Scientific Officer of the International Myopia Institute, which is an organization for you as practitioners to bring together the huge amount of knowledge that is now published on myopia. And every year we have more and more peer-reviewed publications on the topic. So it's really helpful to bring those together in a summary for practitioners. I also acknowledge my co-workers, including Yasmin Wayeb, who's done a lot of the collation of the data and is my most recent PhD graduate. So this is the results of a survey that we've been running since 2015. So we now have 10 years worth of data on attitudes across the world. It started with about 1,000 practitioners responding to this survey. Now we're up to about 3,000 responding to it. And these reports are freely available to you on the web. So this is a survey where we break down the data into the different continents, and also it covers all eye care professionals, mainly optometrists and ophthalmologists. So the first question we ask is about the level of concern with young progressing myopes in your practice. And as we can see, the levels are very high across the globe, highest in Asia. So on the picture on the right-hand side, the arrows away from Asia indicate that it is the highest level, and there will be other diagrams in that kind of representation. And also we've seen a steady increase in many countries and many continents across the world, although it's always been high in Asia over that period. We also asked practitioners what they perceive to be the most effective myopia control treatments. And you can see that for the majority of practitioners, they have now moved on to believing that combination therapies, so not just an optical treatment or a pharmaceutical treatment or a light treatment, but combinations of those are the most effective. Now, you will see later that not many practitioners are actually doing combination therapy yet, but that's what they're thinking. Second on their list is orthokeratology. Third are myopia control spectacles. And fourth are myopia control soft contact lenses. On the other side, the things that they feel are least effective are undercorrection, single vision spectacles, and single vision contact lenses. And we know that is the case. In terms of perceived proactiveness, so this follows concern, we can see a steady increase over the years, over the 10 years that this survey follows, across all of the continents. And we've lost my slides. We may get them back. So again, highest in Asia, but high across the board. So again, it just reiterates how important this topic is and why conferences like this are so important. For the first time this last year, we asked about access to instrumentation, because as we saw in the workshop that we ran yesterday, instrumentation is really important to help us inform us about the progression of a child, when to start treatment, when to stop treatment. And you can see across the board access to things like cycloplegic refraction are very high, as it is autorefraction. Interestingly, the figures are highest in Asia for access to instrumentation, so that's very good, but actually quite low in some areas, such as biometry in Europe. So some nations are still catching up in terms of the instrumentation that they have access to. And of course, it's acknowledged that some of this instrumentation is relatively expensive for practices, but the technology is getting cheaper, and there are already ways that we're working on with, for example, your smartphone to be able to measure biometry, which will totally change how we're able to use this instrumentation. Can you move on to the next slide? In terms of then the frequency of prescribing, so we ask people what they've prescribed over the last month, and then we break that down by the different categories. So you can see, despite the concern about myopia and people feeling they're being proactive, a lot of them are still prescribing single vision spectacles. So it has declined over the years, although leveled off in the last year. There's been an increase in myopia control spectacles since they were introduced to the market. Again, an increase in contact lenses, soft contact lenses, specifically for myopia control. Orthokeratology has stayed around the same, but now maybe a slight drop-off. If we look at pharmaceutical treatment, there was a big jump from 2015 to 2018 in terms of the number of people using pharmaceuticals, and it has largely leveled off since then. In the last survey, we broke it down into the different percentages that people are using, the most common being 0.01%, very few people using more than 0.05%. Although the latest papers suggest that 0.01% may not be that effective, and so we may want a higher dose. In terms of the minimum age for prescribing, it really breaks down into contact lenses or spectacles. In terms of spectacles, people are very happy to prescribe around the age of 6 years, and that is when we generally know that a child is going to go myopic. It tends to be more around 10 years of age that people are willing to prescribe contact lenses to children. But we all know that there are some children who are very mature and we can fit them younger, some that actually we probably need to wait till later. So more variability when it comes to that. When it comes to pharmaceuticals, again, we're generally willing to prescribe those to a relatively early age, so maybe fractionally later than spectacle lenses. In terms of the degree of myopia before people prescribe, it has leveled off to about 1 diopter. So when people are 1 diopter myopic, on average, practitioners will prescribe. Now, arguably, the quickest rate of progression is at that very early stage, And so if we want to be most effective, we want to prescribe as early as possible. So even 1 diopter is probably very late. And we also know that the risk goes up even in that first diopter. So catching children very early, looking at that pre-myopic stage when they have a low amount of hypermetropia, and preparing parents that we might need to prescribe for them is important for the future. And when we look at the rate of progression, again, people feel that that's about half a diopter a year that they would consider being of concern. Of course, measuring the rate of progression is difficult because that needs us to be seeing that child very regularly, and we don't really want to wait if they're myopic already. We want to prescribe. In terms of underprescription, we know that if we undercorrect a child, it may do nothing. It may actually accelerate their myopia. So we can see across Asia that largely people are not doing this practice, but still about 20% are. In places like Australia, it's virtually none now. So hopefully this is an important message to get across, that having an optimum prescription, even if they can't afford myopia control treatments, is really important. The factors for those people who are not prescribing myopia control at the moment is mainly due to economics. So people feel that the treatments are expensive. Interestingly, over the years, people now feel more informed. That's no longer a big reason in most continents for people not prescribing. And in terms of those that aren't prescribing, it's about half of the population in Asia, half of eye care practitioners in Asia. It's about a quarter in places like Europe and Australasia. So what are the factors for starting myopia control? It's mainly due to the age of the patient and also the refractive error. We also see up the top there things like axial length for people who can measure that, and myopic progression. So these are the main drivers that people use to decide to start myopia management, which are very sensible. We also see up there the number of myopic parents. This is the best factor that we have for the genetics. So again, asking whether a child has parents who are myopic also helps in that decision making. Factors for choosing between treatments. Again, this largely comes down to patient's age, and the most effective treatment for a child will be the one that they are willing to use. So if they take their spectacles off all the time, that will not be effective. But if they are unable to put contact lenses in, that will also not be effective. So it's that choice of treatment at the moment. Most of them are equivalent in their effectiveness, but it's the one that you will actually be able to use with that child. And in terms of the frequency between follow-ups, that is generally between 3 and 6 months. Interestingly, in Asia, it tends to be earlier than in other continents, so more likely to be 3 months than 6 months. The triggers to adjust a treatment is largely to do with refractive error progression and axial length progression. And again, that makes sense, but also consideration of new treatments that have become available, and we're getting those all the time. Compliance, because if the child is not using the treatment, it won't be effective, and any complications. And in terms of the impact on your practice, this is something that we've asked in the last couple of surveys. We show consistently that actually our patients are more loyal. If we offer myopia control, practice revenue increases and job satisfaction increases. So again, for the practitioner, this is a really valuable part of your practice, not just for your patients, but also for you. So these are the sponsors of the IMI, which is a totally available organization there for you as practitioners. So this is one of the latest reports that will be published this year. We'll have an update on the global prevalence. So following up on the Brian Holden 2016 paper that is often cited about how many people are myopic and how many people will go myopic in the future. Is myopia a public health issue? The survey, as we've got there, updates on myopia control treatments, light and myopia, so some of the new light treatments, instrumentation, and a digest which brings up to date all of the other IMI reports. So these will be freely published in the journal Investigative Ophthalmology and Visual Science. And I would encourage you to join the IMI. It's free, but also to get hold of these reports because it's a good way of keeping up to date. So thank you again for your attention this morning.
Thank you so much, Dr. James, for your insightful presentation. And the part where we made your screen disappear was on purpose, so you can experience the full Pakistani experience with technology. Thank you so much. I would now request our very esteemed speaker, Professor Dr. Sohail Sarwar, to please come on stage for his scientific presentation. Thank you so much, sir.
Next. दूसरी presentation. I have two presentations to deliver, and this was my second presentation. The first presentation is what are the challenges which we meet while doing the biometry in myopic eyes. So myopic eyes, they get early cataract in their life, particularly starting from nuclear sclerosis. And by reaching the age of adult, normally they are already having NS 0.5 or NS1 cataract in their eyes. So biometry surprises in myopic eyes. Before going into detail of the science of biometry, all of you must understand this words or a couple of these words, radial basis function. What is a radial basis function? It has nothing to do with the science. It has nothing to do with the myopia. It has nothing to do with the medicine. And what is actually radial basis function is, this is self-explanatory. There are simple functions and there are radial basis functions. We will talk into detail this word radial basis function, how we will apply it in myopia biometry. So in myopic biometry, we will have two surprises. Either we will end up with a hyperopic patient or we will end up a myopic patient. Both the biometry was done and 16 diopters was the result on biometry. We implanted in the eye, but in some eyes you get plus surprise and in some patients you get the minus surprises. There are two different reasons for it. Why you get plus surprises, what is the reason of plus surprise, and what are the types of eyes or what is the problem which give you -2 diopters surprise. Let's go for the first one. How will we end up with the plus diopter error in myopic biometry? We have ultrasound biometers, we have ultrasound applanations, immersions, gel blob techniques, and then we have non-contact laser beam these two types of instruments, they are being used for axial measurements. And ultrasound biometry is the most important. We have to learn the art of ultrasound biometry because only the 10% in the population, this population is increasing, this hospitals, they are increasing, which are having non-contact biometer. It's very expensive instrument. And even if non-contact biometer is there, side by side, there must be lying an ultrasound biometer to do the biometry or to confirm the non-contact biometer. So we will first go into detail of the ultrasound biometry. What we do in ultrasound biometry, the sound waves enters and it gives these spikes to give the axial length of the eye. And similarly, in myopic eyes, same behavior, we can see it, and you can see if myopia, there is a posterior staphyloma. The posterior staphyloma may be of many types. It may be involving the macular area, or it may be involving optic nerve head area, or it may be involving the area nasal to the optic nerve. So there are many types of myopia you can see. And if particularly there is a myopia which is only involving the macular area, there is no problem in the axial length. But most of the time, we are having the myopia which is involving the disc area or the area which is nasal to the disc. And in these cases, when we are doing the ultrasound biometry, we will get this type of spikes. The retinal spikes, they are not coming up to the threshold level of the machine, and we erroneously detect that our probe is not aligned properly. So we purposefully align, or in other words, we misalign the probe, and what we do is that we shift our probe towards the area where we will get the maximum spike. And this maximum spike gives you an erroneous axial length. The measured axial length was this one, but the actual axial length was this one. So now we have made the calculation of intraocular lens power, which will be less in power as compared to the what we are designing. So implanted IUL power was low in intensity, but the required was higher. So this gives an error of +2 diopters. Now we come, and what is the remedy of this +2 diopters? You have to shift your A-scan biometry to B-scan biometry, or you have to shift to the non-contact biometers. And this is a remedy for this erroneous axial length measurement on A-scans. Now we come to the second problem where we can get the minus power error, and this is mainly depends upon the formula errors. And now we will come to the another chapter of this. My presentation is what formula we have to use in myopic eyes. We have many formulas. They were starting from previously in early years, theoretical formula, then regression formulas, then hybrid formulas. Now regression optimized radial basic functions. This is radial basic function what I was talking about in my early slides. And now there are AI based formulas. And there are, believe me, till now, what is the day today? Yesterday I was browsing, there are 23 formulas for intraocular lens calculation. If you have 23 answers for a question, it means that question has no answer. Next slide. Actually, the problem with the formula is that we want to capture a formula that should apply on 16 billion eyes of this world population, and that's not possible. Every eye is different from the other eye. So can I go? Another thing is that with this formula, with all the formula, remember one thing, myopic eye, they have a tendency to become myopic after biometry, whatever formula you use. And hyperopic eyes tends to be hyperopic, remains hyperopic after the formula, whatever formula you use, this is my experience, and this is a quotation that I have read in many literature. Okay, we know that there are two general main parameters which affect the outcome, and one is the K reading and other is axial, and these are the two most important parameters. But there must be and there may be many more parameters which affect the biometry, including the temperature of your probe, including the humidity of your environment, and whatever. You can include thousands and thousands of parameters which can affect your the IOL power calculation. So we generally know that white to white distance is related to K reading, and it affects the K reading. And similarly, the AC depth and axial length, they are related to each other. But what we have done is that ACD depth and axial length, we take the two parameters, and then these formulas make a hidden effect in between. And from this limb, from the left side, there is again, then at the end, the IOL power is calculated. But the story doesn't end here. There are many formulas, there are many parameters, sorry, which affect each other. Even a distant parameter can affect a distant other parameters which seems not to be related to each other. So this is how then a dependent parameter is calculated. This is radial basis function. This radial basis function is actually AI learning, a deep procedure in that, and this is all these formulas, they are dependent upon artificial intelligence calculation. So there are many formulas now, AI based formulas, and this picture, everybody know that this is a very popular picture on internet available, and you can see that there is a formula at the bottom which is Hill RBF, radial basis function, which is covering almost takriban all the axial lengths, short eyes, normal eyes, and long eyes. These are AI-based formulas. Hill RBF is one of the top one, or the first one, and which is still existing is Hill RBF, then Kane formula, the Pearl DGS, and many, many more. There are 20. And this is an article which was published in 1st January 2025, not more than a month ago. So the title of this one was Prediction of 7 artificial intelligence-based intraocular lens power calculation formulas in medium-long Caucasian eyes. And this was the title. And what they have summarized in that, they put all the formula and measure their efficiency on on these 3 bases. And if you want to assess a formula, you have to take 3 biostatistics functions on it. One is root mean square of absolute error. Second is median absolute error. You can check a formula on median absolute error. And thirdly, you can check if efficiency of a formula with the prediction error within 0.5 diopters. And let's see how these 7 formulas stand on these functions. There are 14 eyes they were studied, and axial length ranging from 24.5 to and higher than this one. They were taken, and in all parameters, in all formulas, Hill RBF was the top leading. So Hill RBF is the recommended formula for myopic eyes, and it is available on internet with the URL of this rbfcalculator.com. So to summarize my presentation here, First of all, you have to convert to the B-scan biometer if you have an ultrasound biometry. Secondly, if you have non-contact biometry, that is better than the B-scan in axial length measurement, and then Hill RBF is the recommended formula for this one. So thank you very much. Any question from this presentation? Then we will go to the next presentation. And मैं तो वैसे इधर ब्रेक देने के लिए ना मेंटल ब्रेक देने के लिए लोगों को कहा था क्योंकि दो प्रेजेंटेशन देना जो है ना वो बड़ा खतरनाक होता है देखें दूसरी प्रेजेंटेशन Can you go to the next presentation? Yes. Yes. It's not a long presentation, it's very short presentation. And the topic for this presentation is biometry in post-LASIK eyes. This is very important, even important than my previous presentation in myopic eye. Why? There are reasons. Why post-refractive surgery biometry is a challenge? Number one, the third one is the most important. The third one is that the patient already has been enjoying 00 VN without glasses throughout it. And he has already gone into a procedure where he has left off his myopic glasses and become a 00 early in his life. So the third one is more important, why it is challenging. Second, the scientific reason for behind this is that the corneal anatomy is disturbed after laser refractive surgery, and anterior and posterior curvature of the corneas lose their relationship. This is the most important factor which affect the biometry in myopic eyes, in post-LASIK eyes. So about the corneal anatomy, we know that all keratometers, they measure the radius of curvature of anterior surface of cornea. They do not measure the diopteric power of the cornea. If we want to know the diopteric power of the cornea, we must convert that radius of curvature into a diopteric formula, diopteric power with the Snellen law, with this formula. Snellen law means this diopter, this is the formula. And if you summarize this, there is a constant in this formula. And that constant is the refractive index of the cornea. This constant is disturbed after refractive surgery. This is the main problem. And that is why we cannot convert the radius of curvature into diopteric power in post-LASIK eyes because this constant is disturbed. And what is the new constant, we don't know. Normal corneas and what is the refractive error, we don't know. We don't know this formula. Does this stands on post-LASIK surgeries or not? Conventional keratometers fails to measure diopteric power of the new cornea. What is the remedy? With the help of corneal topographers, corneal topography, we measure the total corneal power. We measure the anterior power of the cornea and we detect the posterior power of the cornea from the anterior surface of the cornea, and this gives us TCP. Every corneal topographer gives us TCP, and for this, the most popular formula till now was the ASCRS.org formula, which was for post-myopic laser surgery patients. And this is the URL interface. Here you can see that you have to incorporate the patient's data and pre-LASIK data if available. Then for K reading, post-LASIK K reading, This is the segment where you have to enter the K readings. And you can appreciate that all of them are based on corneal topographers. If you have Galilei, if you have Tomei ACP, IS, ERP, topography, and the 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, these are all topographic data which we have to put in these formulas. Next, with the help of ultrasound or ultrasound or non-contact biometry, the axial length measurement, they are put here. And next, we have to calculate the power of the lens. But in 2008, there comes a formula, which is Haigis L formula. And this is very important formula. And this I will go into detail. What is it? Haigis L formula, it is basically not a biometry formula. It is a formula to convert the K reading to get a new K reading that will be used in the formulas. So this is a correction factor for the K reading. Haigis L formula is not for biometry. It is for correction factor for K readings. So this is the formula. This is freely available on the net. And I have already told you that what is the difference between Haigis formula is for biometry, only Haigis formula. And Haigis L formula is for K reading correction. Haigis L formula is not for the biometry. So this is, you can see that if you have measured biometry of 7.70, then you have to correct it to, after getting the formula, to 7.86. And so long, if you have 8.6, you have to correct it after getting the Haigis L formula. You have to put the K reading as 8.84, not the 8.60. Similarly, if you are having, because the myopic post-LASIK eyes, they are going flatter and flatter. And they are, if the previous number was high, they are going towards on that side. If you have 9.7 millimeter of base curve formula, then you have to put in your formulas 10.41. So this values we got from Haigis formula, Haigis L formula. So what is my recommendation? My recommendation is that you don't have a need to have a corneal topography. Just do biometry with your ordinary equipments, with whatever the equipment you are using for axial length measurement. You can get this Haigis take K reading from your routine equipment. No need of corneal topography. Adjust the K reading with the help of Haigis L formula that is available on the net. You can download in your Excel sheet or in your calculator. Do routine biometry and calculations. And what formula you have to use? I will tell you. In my previous talk, I was recommending Hill RBF. But I will negate Hill RBF and come to our basics things. I will tell you how. Never use Haigis formula. I hate Haigis formula. It's giving very wrong and very high powers, and it's not effective. Even one in my life, in my private patient, he was unhappy because he turned up minus 2.5 diopters myope. And believe me, I have to return all his money he gave to me to back, and I have to excuse him. And there's long story. Next. Formula. Which formula to use? I was recommending Hill RBF, but now I will recommend you that these formulas, SRKT formula, Holade, and Hoffer Q, these all are available in your biometers. Use the middle value of all these threes. That will be effective. That will be equal to Hill RBF. And a big no to Haigis formula. Do not use Haigis formula. So to summarize my presentation, again, same thing, normal keratometer failed to measure the K readings. ASERS can be used, but now Hagel's L formula with routine biometry is my message for my presentation, and do not use Hagel's formula. Thank you very much.
Thank you so much, sir, for your very enlightening presentations. And we all learned a lot about the calculations for refraction in myopia. I would now request our esteemed guest and speaker, Professor Dr. Nasir Chaudhry. Professor Dr. Nasir Chaudhry is a renowned and esteemed ophthalmologist. He's professor of ophthalmology at King Edward Medical University. And another introduction, which is near to me, is that he is also a fellow medical educationist. Welcome, sir. Please come on stage for your enlightening presentation. Thank you. I would also like to welcome Professor Dr. Christopher Liu, who has joined us remotely. We will be hearing from him soon also. Welcome, Dr. Christopher. Thank you.
Thank you very much, Dr. Komal, for the kind words. And this is such a delight to be here with elegance and elite of medical profession. I would like to extend my deep gratitude to Honorable and worthy Professor Dr. Amar Chaudhry, my ever-great teacher, Professor Dr. Asad Aslam Khan, Professor Amanullah, many of my teachers sitting in front of me, Professor Dr. Sultan, Professor Zahid, Bhatti Saab, and esteemed national and international speakers, prestigious gathering from different institutions of country. So I had to be here. Myopia is basically a pandemic, which poses a great challenge, a public health issue, and a significant implication as regards of financial, psychological, and visual perspectives. With mounting evidence from 30% to 50% by 2050. Being one of the leading cause of irreversible visual loss, and you can precisely witness the behavior of myopic macular degeneration, which starts earlier, more aggressive than the normal age-related. The behavior of myopic macular hole, which starts with foveal schisis, foveal traction, foveal detachment, different from the normal age-related macular hole. Then the PVT associated with myopia, which is again more aggressive and more rapid. So I would like to applaud the incredible efforts of Medina Medical University for arranging this gigantic academic activity, which is a need of time. And this is the reason why the people are now talking about what is pre-myopia. So well-directed and timely needed and executed conference as regards of prevention of myopia. So next slide, please. With the substantial advancement and progression and development in the refractive surgeries, there is a growing challenge to get rid of horribly thick glasses and droopy eyelids because of excessive use of contact lenses. But at the same time, you have to be vigilant. I will have to talk about the femtolisic, challenges of femtolisic as regards of high myopia. Currently, we have seen a lot of innovative procedures like SMILE. Though the SMILE has the advantage of dry eye over the conventional LASIK, then keeping in consideration of biomechanics, and then it's more precision and it avoids the flap-related complications. But in our perspective, the gold standard is still the femtolasic. So high myopia normally falls in the category of pathological myopia with refractive error more than 6 diopter and axial length more than 26 millimeter. And I have to specially talk about the frequently encountered scenario. Like many of the time, the people will come to you that I have a night duty and I have to spend more my time while driving at night. So he has to be very worried, and he is worried regarding the night vision issues, glare, starbursts, like these sorts of issues after femtolase. Then many of the patients will discuss with you the dry eyes related issue. Then many of the patients, they come and they discuss that either I can be a good candidate of laser or not because of peripheral degeneration like lattice degeneration. Then, and in cases of these high myopia, because of the retinal thinning and progressive, or you can say the aggressive ablation in case of reshaping of the cornea, there can be a post-operative, post-LASIK ectasia. So I will try to address in my humble domain these issues. We have witnessed a paradigm shift as regards of ophthalmological advancement. You can see 1988 was the first photorefractive surgery PRK done. And in 2000, there was a FDA approved femtolesic surgery. इससे पहले in 1896 दो बैराक्वेर के भी नाइफ भी अगर आपने देखा होगा तो उसके कैरेटोम भी अवेलेबल है. In 1896, he used to remove the cornea from the human eye, reshape it, thaw it, and then used to restitch it. And just in a matter of 12 years, there was a paradigm shift from PRK to femtolesic FDA approved. As I've already talked, smile, minimally invasive, avoids flap-related complications, advantages of biomechanic stability, and dry eye-related issue. But maybe one of the reason there is a long learning curve associated with the smile. So in our part of the country, the most reliable or with that is associated with early visual rehabilitation is still a femtolesic. It has additional, the newly equipped machine or femtolesic, they are incorporated with the wavefront guided because they precisely take the images of the cornea, and even they are able to address the higher order aberration. That is also a frequently encountered scenario after LASIK in some cases. Normally, everyone is aware that it has to be, refraction should be stable. Corneal thickness must meet the criteria that is very important because this is one of the important determining factor which will avoid the post-LASIK ectasia. Then the tear film stability. Contraindications like autoimmune diseases because they normally delay the healing and aggravate the dry eye related issues. Uncontrolled diabetes and pregnancy and lactation that affects the hormonal changes, and ultimately sometimes it causes refractive shift, sometimes causes a delayed healing also. For post-LASIK ectasia, the normal screening tools can be corneal topography. The new machine which are doing PRK, they are usually incorporated with the topography. While the femtoliths, they are associated, usually incorporated with the wavefront guided techniques. Then ocular biomechanics, corneal pachymetry, and anterior segment OCT. The risk factor which can promote post-LASIK ectasia, they can be aggressive ablation, thin preoperative cornea, high myopia, and then eye rubbing plays some part. Like we used to calculate the target pressure in case of glaucoma, there is a certain formulas which can give you some sort of idea that this can be patient, this can be candidate for the laser, and this patient is not going to end up with the post-LASIK ectasia. So flap thickness, normally it varies from 80 to 120, and then the ablation depth. Flap thickness and ablation depth divided by the preoperative thickness part of the cornea. So that will give you percentage, that is PTA. And if it is less than 40%, so this is considered as safe. Another criteria that is all, it's easily manageable while going through clinical examination and topographic like pentacam or Galili scan. We can diagnose the keratoconus, but me criteria, this is a different one because it incorporates clinical finding as well as topographic finding, and this will give you a precise idea about the diagnosis of the keratoconus. So you are not going to proceed with the laser in these cases. Then there is another criteria, a formula that is KISA. That is another criteria which will give you a precise idea that you will not end up with a post-LASIK ectasia. Keratometry, inferior is and minus superior. Corneal astigmatism K1, K2, SIM K is, we know that is a central 3 millimeter curvature. Okay. And then skewing of the radial axis mean normally we have bow tie pattern. Atypical bow tie pattern is a skewing of the radial axis. Ectasia, many of the surgeons, if you go through a extensive literature, I normally, while I operate with femtolasic, I tend to leave behind a bed of about 290, at least 290. Many of the literature you will see that 250. So if you are leaving a bed of 240 or 250, this patient can end up with the post-LASIK ectasia. And this will fall in the category of score 4, 0.3, 0.4, 0.3, 240 to 260. And the error is between -12 to -14. Then 260 to 80. So 290 to 300 is considered as the safe bed in addition to the flap. Dry eye related. So, in addition to looking for clinical examination, tear meniscus, tear film breakup time, and Shermer, tear film breakup time less than 5 seconds, and with Shermer less than 5 millimeter wetting, that will give you an idea that this patient will not be appropriate candidate for the femtolasic. Normally, femtolasic, because we will go through the forthcoming slides. Normally, femtolasic that induces some sort of intracorneal damage. some sort of mammalian gland dysfunction, some sort of damage to the goblet cells, and some sort of tear film instability because of the reshaping of the or ablation of the cornea. But these all factors will tend to normalize after 3 to 6 months. So pupil size, another important criteria while going for femtoLASIK. Uh, in the with the before the recent advancement, like we have currently Z8 and Schwinn Emrys limited edition, they are incorporated with the SMILE profile also, and wavefront technique also. So pupil size is not a concern nowadays with the recent modalities. Because with the larger pupil size, you can have, or with the larger ablation, you can have some sort of irregularities of the cornea in terms of that end up with the higher order abrasions like trefoil, tetrafoil, comma abrasions, and then like starbursts, night vision disturbances, contrast sensitivity, glare, and starbursts. So these are the patients which can be at the risk for higher order abrasions. What are lower order abrasions? The people sitting. Lower order abrasions are normally hyperopia, myopia, and astigmatism. So the higher order abrasions, which are trefoil, tetrafoil, and comma abrasions, and these are basically because of surface irregularities. Now, as regards of lattice, peripheral degenerations or lattice, there are different perspectives. If a patient is symptomatic means he has a history of flashes or retinal thinning, retinal holes, or retractions associated with the breaks. All the symptomatic patients are recommended in addition to other indications like family history, detachment in the other eye. Symptomatic and all the peripheral retinal degeneration associated with the hole, they are treated with the barrage lasers, and many of this literature, as suggested by the literature, this suggests that this will give you stability after around 2 weeks. But I am more safe in that regard. I would tend to operate these patients after 3 months. So after stability of 3 months, now either I will have to go for femtoLASIK or PRK. Again, I will have to be even more conservative, because many of the surgeons, many of the literatures, or many of the people, they say you have laced the peripheral retina degenerations. It has given you stability after 2 weeks, but you can start and you can operate these patients with femtoLASIK after either 2 weeks to 3 months. But I am conservative. I will shift from femtoLASIK to PRK. I tend to shift because with the shocks of femtosecond, with the suction applied, vacuum and IOP changes, and effect on the PVD. Because after femtoLASIK, there is 85% chance this patient will end up with PVD after 4 weeks. And about 10 to 15% chance the PVD will occur after 2 days. So to avoid these risks, to be more conservative, to be more careful, I tend to switch from femtolastic to PRK after treating. And even a normal patient, if there is no break, no traction, there are lattice regeneration. The second eye is the normal. Many of the studies, people, there are intersurgeonal variations. Many of the people, they proceed with the femtolastic or PRK, but I even sometimes remain careful, and again I will switch from femtolastic to PRK to avoid femto-related shock waves, PVD-related issues, and it's better to be safe. These are commonly encountered, not so commonly encountered, but common implications of femtolastic. Thin or incomplete flap, everyone knows. You can manage these, you can defer, and you can perform PRK after 3 months. Buttonhole flaps, again, you can abort the procedure at the time, and then deeper flap after 3 months. Free cap, sometimes you can end up with, and this time you can switch from femtolastic to PRK. Sometimes while performing femtolastic, while creating flap, you end up with this opaque bubble layer. But this is not normally problem if it is below the flap. You can just remove it with the help of the gentle movement of the spatula. Corneal epithelial defects, you can apply bandage contact lens. Haze can be managed with mitomycin. So as regards of dry eye, these are the factors which can be associated with post-LASIK dry eye related issues. Nerve damage, decreased corneal sensitivity, tear film instability, meibomian gland dysfunction, or pre-existing dry eye, or goblet related mucin, and then ultimately leading to dry eye. So we have already gone through these slides. Micro, you have to encounter sometimes you have to face micro and macro stria. Micro stria, normally it will go away. No need to do anything. But in case of macro stria, because it causes visual disturbances, you have to lift the flap, wash it, and very rarely you have to apply even compression sutures also, but that is very rare. Normally, lifting it, wash it, and gently going through the other side of the cornea, that will manage the macrostria. Diffuse lamellar keratitis, another commonly not that much common, but if it is there, that can be treated with conservative management with topical drops. Post LASIK ectasia is again important. In cases where you end up with aggressive ablation, young patient, high refractive error, so preoperative clinical and scans will give you some idea. And as I have already discussed, few formulas like PT and KISA, this will give you an idea that you should go for refractive surgery or not. Post-LASIK ectasia, You have to be very watchful, very carefully evaluate post operatively. And there is just a posterior steepening, posterior elevation on the pentacam and the scan that can be picked even in our early cases, and then you can manage it accordingly. Steepening of the posterior corneal surface, increased posterior elevation, that will give you a firm idea that this patient will end up with a post-LASIK ectasia, and this needs to be careful and vigilant observation and treatment with the CXL when required. So these are the pictures showing posterior map elevation, steepening of the posterior curvature. So risk factor can be, again, young age, aggressive ablation, inappropriate preoperative or inaccurate measurements. The new machines like wavefront guided, they tend to increase the ablation zone. Normally, one of the reason of high rate of abrasion, that your treated and untreated zone comes within the pupillary diameter at night. So with the newer machine, enlarging the ablation zone, and some people call it as blend, reshaping or beveling the remaining normal cornea. So with these measures, you can avoid post-LASIK ectasia. Sorry, high radar abrasions. LASIK extra, many of the, I was talking about post-LASIK ectasia. Many of the people, they tend to combine femtoLASIK with CXL in borderline cases to avoid the complications of post-LASIK ectasia in selected cases. So it was all about. Any question? Thank you very much.
Thank you so much, Professor Nasir, for such an enlightening presentation. I would like to now introduce the last speaker for this scientific session. We are joined online by Professor Dr. Christopher Liu, consultant ophthalmologist and honorary treasurer of the Royal College of Ophthalmology, UK. Professor Christopher has been very kind to join us today. He has also been supporting the Myopia conferences previously. We are going to listen to his recording, and he is present for any question and answer sessions later. Thank you.
Hello and welcome to this An Educator's Guide to Myopia Management. My name is Indy Growell. I'm an optometrist based
W. I am an ophthalmologist specializing in corneal cataract and refractive surgery. I am based in the UK, working in my private practice in Brighton and my NHS corneal practice in the Scottish Highlands. In Hong Kong, I have two roles. I am the lead consultant for the hospital authority, and I also lead a surgical refractive practice. The surgical refractive practice, which I lead, is in Euro Eyes Clinic, the flagship clinic in Hong Kong. You all know about non-surgical treatments of presbyopia. Essentially, these are glasses, which can be bifocal or varifocal, contact lenses, which can be multifocal or monovision, and there is some resurgence of interest in pharmacological treatment, which basically is using a miotic in one eye, converting that into a myopic eye for reading. In terms of surgical treatment, it could be work on the cornea or lens replacement. So keratorefractive surgery has to be done in the absence of cataracts. This preserves residual accommodation, which even in old age can be up to 1 diopter. There will be less glare and halos compared with multifocal implants. You can simulate monovision if they have had successful monovision contact lens wear. And you can create multifocal corneae, or you can manipulate spherical aberration in order to increase the depth of field. So this is what is deployed with Presbyond, which I will go into in more detail. In terms of lens replacement, this would be necessary in the presence of cataract, but it can also be done in the absence of cataract. In terms of refractive aim, we can go for monovision or mini monovision, which can be done in combination with EDOF implants. And then, of course, there is the ever popular trifocal implants, but we must always be aware that all patients will get glare and halos with every single trifocal. It's just a matter of extent and whether it fades away based on the patient's personality. Let's have a look at monovision and mini monovision, which you are all familiar with. Now, with traditional monovision, the dominant eye is corrected for distance and the non-dominant for near. Now, you need to remember that only 2/3 of the population can tolerate monovision. On the other hand, with mini monovision, you can correct either eye for distance and the other eye for intermediate vision, let's say aiming for -1. And the good thing is that more or less 100% of the population can tolerate this. In the absence of previous contact lens monovision wear, then mini monovision is much safer. And you must remember that it is impossible to test for tolerance of monovision or even determine which eye is dominant when there is any amount of cataract. Let's have a look at Presbyon or blended vision lasik invented by Professor Dan Reinstein on the Zeiss platform. And I thank him for the ensuing slides and help from Dr. Miramadou, who is a colleague at Euro Eyes in Hamburg. The dominant eye is corrected for distance and through deliberate linear spherical aberration gives a depth of field of 1.5 diopters. The non-dominant eye is corrected for near, and again there is a depth field, so there is a blend zone where the two eyes can work together. Lens without spherical aberration will bring parallel rays into one particular focus, so that single focal point will have very sharp vision, whereas a spherical lens will bring parallel rays into a range of focal length, the peripheral rays being focused further in. So in this depth field, there is a clear enough vision, but not completely clear. Whereas without spherical aberration, there's only one point of clearness. Now, with the help of neuroprocessing, that depth of field is sharpened into a focus which is similar to a lens without spherical aberration. Now, using nonlinear aspheric presbyopic ablation profiles, it increases the depth of field. So let's have a look at the influence of spherical aberration on depth of field. So on the top here, you see without spherical aberration at 7 mm pupil size, then there is progressive defocus as the eye is made more myopic. Whereas with spherical aberration, you can see that with progressive defocus, there is still some sharpness even at -1 or -1.5. Now, with neuroprocessing, the non-dominant eye can see up to -0.5. So let's have a look at simulation for -1.5 defocus with a 7 mm pupil. Now, if we add deliberate spherical aberration, it sharpens up a bit. And then if we reduce the pupil size to 4 mm, then it's even sharper. And with the two together, it's quite sharp. And then you add neuroprocessing, and it is really very sharp. So based on the results of Presbeyond, I recommended my now middle-aged wife to have Presbeyond, which Professor Reinstein very kindly carried out for her, and she's very happy. I mean, she did need retreatment, and you have to remember there is a retreatment rate for Presbeyond. Well, let's have a look at lens replacement surgery, which is the other strategy. And it's also called clear lens extraction, refractive lens exchange, or cataract surgery if there were cataracts. Now, what are premium IOLs? Generally speaking, premium is a term with quality connotations, but in practice, when we're talking about premium IOLs, it is a marketing term for positioning and profit. We're talking about toric IOLs and presbyopia IOLs. Correction of astigmatism is really, really important when somebody is seeking spectacle independence. There are a few tips. Topography is important. Limbo-relaxing incisions is really out of fashion in that it is unpredictable, it's unstable, it severs nerves and therefore gives a dry eye sensation. Eye marking is important while sitting up with both eyes open and before using any local anesthetic injection or infiltration. Of course, if you have Callisto or similar arrangements, then it is very, very accurate, but eye marking is equally satisfactory. Now, in terms of reducing the risk of toric IOL rotation, then intraoperatively adjust the implant axis after removal of ophthalmic viscoelastic device and reinflation of the eye. It can be more stable. And postoperatively, early follow-up is essential, and redial of the implant to the correct axis. Early redial is important. So, using an implant approach, what are the strategies to correct presbyopia? Well, of course, if there has been successful contact lens monovision, then that can be replicated with IOL monovision. But remember, the residual one diopter of accommodation will be removed. So it may be necessary to correct the near eye a little bit more than when done with contact lens monovision. Well, mini monovision is tolerated by more or less all patients, and ocular dominance is not so important. So you can do that so that you can have one eye for distance and the other eye for intermediate. Now, this, when combined with EDOF lenses, which let's say give one diopter of some kind of accommodation, you will have the dominant eye from 0 to -1 and the non-dominant eye from -1 to -2. So that is quite satisfactory, but patients will need to be warned that for any serious amount of reading, then they will need to have top-up reading glasses. As I mentioned earlier, all multifocal implants will give rise to glare and halos. So personality assessment is really important. So by that, I mean the happy-go-lucky and the not very particular kind of person will be suitable. The person who asks you many, many questions and they will say, oh, just one more question, doctor, and then comes another one. They may not be suitable for multifocal implants. Ocular surface assessment also very important because a poor ocular surface will result in poorer outcome. And equally, if the patient has had keratorefractive surgery before, if they don't have any night vision problems, then they are probably likely to be suitable for multifocal implants. But whereas if they have night vision problems and glare and halos, then probably best not to add to the complexity of the optical system with a multifocal implant. I think avoid in AMD and glaucoma and in dementia as well, when the brain is less able to work on the complex optics. On the other hand, phuxis endothelial dystrophy is not a contraindication, but watch for IOL opacification. So it's important to choose a multifocal implant which is made from hydrophobic material, and they are less likely to become opacified in the presence of air or SF6 used during DMEC surgery. So, how do you choose multifocal versus EDOF? Well, multifocal, they will give distance intermediate, so for social interactions and reading vision, and they're mostly diffractive, and they will all have glare halos and require more light for reading. Whereas with EDOF, there's less accommodation, perhaps gives a one diopter add, and the optical mechanism varies, but it is also possible to emulate presbyon using mini monovision and EDOF. Now, what do people want in Hong Kong? Well, they're actually preferring trifocal implants because they feel that it's a once and for all procedure. How about me? If you look at the top picture, that's me and my old son, who is now a junior doctor seeking to become trained in ophthalmology. Well, I have had LASIK before in 2002, and so I have multifocal cornea, and I have been offered presbyon, which I am considering. As a practical guide, where there is no cataract, then I think we must consider presbyon, remembering there is a retreatment rate. If there's cataract present, then trifocal, if ocular surface, corneal shape, macula, and optic health are all good and with a suitable personality. EDOF with mini monovision for less suitable cases, and monovision for those with a history of contact lens monovision. I think it is important to fully address corneal astigmatism for those seeking spectacle independence. Now be ready to deal with unhappy patients through reassurance, waiting, and further surgery as necessary. Thank you very much, and these are my email addresses if you should have any questions.
Thank you so much, Professor Christopher. If you could kindly open your camera now, because we are starting the question and answer session. So for the question and answer session, the audience is requested to please specify the speaker who they are asking the question from, and please kindly raise their hand so that our person can come with the mic towards them. You may start with your queries, please.
Same in all kind of reflective procedures, trans-PRK, PRK, or LASIK and SMILE, and all are creating the same level of problem while calculating the intraocular lens power calculation. And why? Another question is that I mean, we know that with each diopter change in the refraction, there is 0.9 change in the refractive power of the cornea. So if even if you're doing 6 or 7 diopter myopia, it's going to give rise about significant change in the IOL power calculation.
Yes,
Is it the change in the refraction of the cornea, or is it the biometer with which we measure the keratometry of the cornea? Which is the important factor?
important factor is change in the anatomy of the corneal curvature.
So why is it like that? We are not measuring the central cornea with the help of the keratometry. Usually the keratometry which we use, it measures the paraaxial,
No. The keratometers, they measure the 3.0 mm of center of the cornea.
Mhm.
It's not measuring the peripheral cornea, or it is not measuring the mid-peripheral cornea. It is measuring the center of the cornea. And secondly, the corneal anatomy is disturbed. It affects two factors. Number one, the Snell's formula that is now is not applicable for this cornea. The second factor is ELP. ELP is effective lens positioning. If you have flat cornea, these all formulas have an inherent function to preempt ELP. In that case, if you have a flat cornea, the ELP is expected to be far near to the cornea than actually it is there. So the second effect of flattening of the corneal surface, one is on the Snell's formula, the other is on calculation of ELP. So that is why the normal cornea or normal corneal radius of curvature measurement is not applicable on routine formulas. You have to convert that reading through Haig's L formula to be effectively used the new corneal curvature for biometry formula.
Because sir, what you mentioned with this formula, you measured the corneal curvature and then you convert it into the diopteric power. The change you mentioned in the corneal curvature is very minimal. It's not like that the change which is occurring after the refractive surgery. It's not according to that. Even if you open that slide, it's very minimal change in the corneal curvature, which you mentioned with your formula. But actually, it should be more like that, more than that.
No.
It's not
The corneal
significant.
curvature depends upon the diopteric power you have removed from the cornea.
It is not
If you have,
significantly changed. With the formula, it was not significantly changed.
No, it is significant for the biometry calculation. While looking at the table, you will say that there is no significant difference, but this minor difference plays a role. If you do not apply Haig's L formula, you will turn up +8 diopter error in myopia. Sometimes.
I mean to say that there should be a significant difference. But according to that slide which you showed, there was a minimal change in the corneal curvature.
For you, it is not a visual difference, but it is a significant difference in calculation.
It should be.
It is there. That is why we are facing this problem.
Is there any simple way to calculate the IOL power following refractive surgery? I mean, there is another concept of putting a contact lens on the cornea and measuring the.
Yes, there are 3 methods. I have been using contact lens method. I have been using history method. And second is ASCR or corneal topography method. But the fourth one I have introduced is Haig's L formula. This is the simplest one for me. And
it's very reliable.
And
Very
it's
reliable.
very reliable. And I have till now on my surgery, I have 8 patients which turned up to minus 0.5 or minus 0.75 only cylinder.
Mm.
And one of those patients is my sister, younger sister. So I have summarized that use your normal equipments, switch the K reading with the help of Haigis L formula, and do not use Haigis formula.
Okay.
And then you will end up with a happy patient.
Sir, another question is that the patients who have got mature cataract and having posterior staphyloma, we cannot go with the optical scan in those patients, of course. Then we have to do the ultrasound, excellent with the help of the ultrasound B scan. I mean, we can reliably put that value there, and it should be we can sleep with that value. We are going to get the correct. And there is a confusion sometimes. You are going to do B scan in patients who are having mature cataract with posterior staphyloma, so we can put that value comfortably.
Yes. You must be expert in doing the ultrasound biometry, because ultrasound biometry is the mainstay of biometry, because the non-contact biometers, they sometimes fail. Either they give the 100% correct measurement, or they don't give any. So if the measurement is there, it is always correct. Sometimes maybe if you have wise ring in front of the fovea, and then you will end up with a erroneous readings. But ultrasound biometry is reliable. You must skill the art of taking the ultrasound biometry.
What is that? I mean, can you guide us a little bit?
Thank you so much, sir.
Any other question?
Another question, my first question is change in the keratometry readings with all sort of refractive laser procedures, trans PRK, SMILE, femtosecond. Is it the same?
I think this end up should be the same. I think I don't know the answer of this exact question. Maybe someone in the hall can answer your question. It must be same after every procedure.
My second question is from Dr. Nasir Chaudhary. Why is there significant difference between the manifest astigmatism and topographic astigmatism? Because this is one of the major factor in for proceeding with the refractive surgery procedures. Why is it like that? I mean, sometimes the patient has got 1.5 diopter of manifest astigmatism, and if you do the topographic, it is something like more than 3 or 3.5, and we cannot proceed with the procedure if it's more than 1.5. So why is it's like that? And what is the safe,
What is your main concern?
Main concern is the difference between
Visual correction or higher order aberration?
proceeding for the refractive surgery. I mean, if there is a difference of more than 1.5 diopter between the manifest astigmatism and topographical astigmatism. So this is one of the risk factors for proceeding for the refractive surgery. And why it is like that? Why topography is giving a different reading while we are what we are getting is the difference one? Why is that different? There is definitely a difference between the two.
Yes, but what I normally tend to do, I will definitely go with best corrected manifest refraction, and then it will be followed by a appropriate correction. As regards of topography, because machines sometimes they can give you a false idea. So that is not that much reliable. It has to be clinically correlated with the best corrected manifest refraction, and that is the what you have gone through refraction. And the people going after LASIK, I think after that are best corrected through a subjective verification.
We go for the subjective, but machine gives you the caution. There is a significant difference. So you can take. Machine usually gives you the caution, and you're going to that.
That gives you caution, but many times you feel a difference between your subjective manifest and then topographic calculations. But better to go.
So, मेरे ख्याल है the basic difference is when we are doing a refraction, either we do by retinoscopy or through autorefractometer. But whereas when we're doing pentacam or grilling scan, there are three-dimensional cameras, and their scanning is considered to be more accurate than our autorefractometer or biretinoscopy. So we find if the difference is more than 1.5,
Yeah.
so we consider the scanning by the pentacam more
More reliable.
appropriate as compared to autorefracto. So
Hmm.
we go by that.
Okay.
Thank you so much, sir. Next question, please.
Pentacam में तो आ जाता है, लेकिन टीवी में क्या था, तो वो expected also. अगर इसकी वैल्यू भी 15 से 20 से ज्यादा हो, 20 से ज्यादा है तो इस वाला रिस्क फैक्टर, लेकिन टीवी में नहीं है.
बेटा वो मांग रहे हैं आमिर साहब।
Pentacam की बता रहे हैं. This is also problem. लेकिन आप देखते हैं कि टीवी के अंदर ये नहीं आता.
किस चीज का थोड़ी
तो few dimension. Angle of deviation है four times. If it is more than 22, we do not proceed for that. This is also a risk factor for the country. टीवी में नहीं है, और Pentacam में है.
Thank you so much, sir. We have just come up with the theme for our next Inshallah sessions. Next question, please. Thank you.
Thank you. My question is to Professor James. First of all, thank you very much for with us in Pakistan on that glorious event on myopia control. And my question will be regarding that. And I would request you to tell you about your choice. You have mentioned the combination therapy. Would this be the better age of the patient of 6 years? And what will be your combination if the patient is willing to adopt the modality? Being a practitioner, you are going to advise, what would be the two choices you would like to decide? Thank you very much.
Thank you for that question. So in terms of combination therapy, we've got optical choices. Those are fairly standard. So then it's whether you add atropine to that or whether you add a light therapy. Those are probably the main ones that we would add. Now, we know progression is fastest when you're youngest. So arguably, that's probably the would be thinking about combination therapy, and particularly if there are lots of risk factors. So if the parents, for example, have high myopia, that the child has a very young age, that they're developing myopia, but it's not syndromic, that's probably the stage we would be thinking about combination therapy. But as the data showed, although practitioners think that that would be very successful, perhaps they're a little bit nervous at the moment about actually starting that. So I think as we progress, we will probably start treating myopia at a younger age and perhaps a little bit more aggressively to stop that initial spurt in growth for those very young children with a high risk factor.
Thank you so much, Dr. James. I would now request Professor Christopher Liu to kindly unmute his mic. And if he has some comments, please, Dr. Christopher, I know you've been here since morning, and we're very grateful to you. Thank you. You're muted. Can you please unmute the mic? Right. I think we're having some connectivity issues with Dr. Christopher. I would now request Professor Dr. Asad Aslam Khan to kindly give his concluding remarks for the session. Dr. Christopher, please do stay with us for a minute as I sort it out. Thank you.
Awesome. Bismillahirrahmanirrahim. Professor Amanullah Malik Sahab, Rector, University of Faisalabad. Professor Amir Ali Chaudhary, my senior. Professor Sultan Sahab, Professor Hashim Sahab, Professor Sarfraz, Professor James, faculty of University of Faisalabad, students, optometrists, ladies and gentlemen, Assalamu alaikum. And of course, Professor Tuel Sahab, Professor Nasir Chaudhary. It's always heartening to come to University of Faisalabad, especially the Department of Ophthalmology, and see the number of students being produced by this department. So I must congratulate Professor Ahmed Chaudhary for the great effort and for the great hard work. I am also bound to congratulate Professor Manullah Saab and Professor Ahmed Chaudhary for selecting a very important topic, which is a topic of the whole globe at the moment, because the problem being faced globally in children is the refractive errors. It is such a huge problem that the World Health Assembly and WHO, they have to make a strategic technical advisory group on SPEC 2030 with the mandate to formulate recommendation and to work out how to address this epidemic of refractive error, especially the myopia. And they have given the target to give us the recommendation to address this issue. Because we all know that because of the current scenario situation of teaching, especially which emerged especially during COVID, and now it is being maintained in many institutions. The online learning, instead of learning on the laptop or desktop computer, the children, they are studying on the mobile phones. And that is perhaps the major reason that every second patient in your clinic, whether it is private clinic or it is a public sector OPD of hospital, and the number of children in coming with refractive errors is tremendously increasing. So this is a serious issue, and we have to address it. Pakistan is very fortunate because of our combined effort of the professionals and the National Committee for Eye Health and the National Ministry of Health and Provincial Health Department. We have established departments of optometry across the country, and the significant number of optometrists are being produced every day. Not only optometrists, but also orthoptics and ophthalmic technologies. And not only they are being produced, but the significant number of seats have been created in the public sector, and against which they have been recruited, and they are working at all levels of healthcare, whether at teaching, district, and sub-district level. And Pakistan is very fortunate that our optometrists are not less than optometrists of any other country. And they are very highly educated. After the BSc honors degree in optometry, a few of them done the PhD. The University of Faisalabad is very lucky. The first PhD in optometry is with them, Dr. Memuna. So they are very lucky. And we are very lucky at the College of Ophthalmology that we have also very brightest optometrists who have done MPhil and now doing a PhD, Aisha Salim, and world-renowned orthoptist Aisha Sarfraz, who is not less than any orthoptist in the world. So Pakistan is very lucky, and we have produced a very competent optometrist, and orthoptists and ophthalmic technologists. And I must say that after College of Ophthalmology at the University of Faisalabad and this challenge, and is one of the leading institutions which is producing optometrists of very high standard in Pakistan. So this credit goes to Professor Amir Saab and of course our rector Professor Manula Saab. The problem is that now in 1999 there was no optometrist in Pakistan. And when we started this optometry in 2004 at College of Ophthalmology at King Edward Mayo Hospital, and then it started at University of Faisalabad and in other part of the country. From none in 1999, now we have more than 2,000 optometrists in the country. Very well placed in public sector and in private sector. Now they are at teaching hospital level, they are at district headquarters hospital level and tehsil headquarters level. And in this, youth have played a very significant role. Sightsavers, CBM, Federal Foundation, and Brian Holder Foundation, they have played significant role in training of these optometrists, especially in the public sector. Now the point is this, we have produced sufficient number of optometrists and they provide the glasses on very scientific basis. Now comes the problem of affordability. We prescribe the glasses, we give the prescription to the patient, but they don't wear because they can't afford the price of the glasses. And if they wear very cheap glasses, then this is more damaging than wearing glasses, when not wearing the glasses. So now we have taken another step that we have started a 2 year diploma course in opticianry, dispensing opticianry at College of Ophthalmology to begin with. And we will be producing a qualified dispensing optician. And our target is that in each public sector hospital and private sector hospital institution they may adopt, that they will start not only this dispensing optician course, but they will also establish optical labs. And these, our target is that these optical labs will be attached to district and tehsil headquarters hospital. They will screen the masses, especially the children and women, and they will send us the prescription and we will provide them high quality, low cost glasses so that patient can put them and the glasses. This is our target. So once again, congratulate Professor Amir Chaudhry Saab, especially the rector, Professor Manula Saab, for creating this opportunity for all of us to address this issue. And I hope that with our aim and our dedication, we will provide not only a good prescription, but also a high quality, low cost glasses to everyone, especially the children. Thank you very much.
Thank you so much, sir, for blessing us with your profound words. I would now request Professor Christopher, if he can hear me now, to please.
Hello, can you all hear me?
Yes, thank you.
Oh, that's wonderful. It's just so wonderful to have a voice. And I'm not forcing myself on asking you to liberate me. So greetings from Hong Kong. I'm very sorry I couldn't be with you in person, but I'm very much with you in spirit. And I've really enjoyed the session. I hope you've enjoyed my rather simple talk, which is rather basic, which I apologize for. I fully echo that it is important for ophthalmologists and optometrists and allied healthcare professionals to all work together as a team and in Britain, where Professor Woolston also works. We have always worked together as teams. In Hong Kong, we don't have a very established optometrist profession, but I think that is also in evolution. So it must be lunchtime there for you. No, it is for me anyway. So I won't keep people much longer away from their coffee. And I just want to thank you, all of you, and Dr. Fatima Iqbal for inviting me. Thank you all.
Thank you so much, Professor Christopher. Thank you for your patience. It was an honor to have you here. I would now request Professor Dr. Asad Aslam Khan to please come on stage for the souvenir distribution ceremony to our worthy speakers, accompanied by Professor Dr. Marla Malik, our worthy rector, Professor Dr. Amarli Chaudhary, Head Department of Optometry. Sir, kindly come on stage. Thank you. Sir, उनको तो आपने award देना है. I would request Dr. Safraz from OSP Faisalabad to please come on stage. We are very grateful to OSP for coming and representing. Sir, का पहला award है, sir. I would now request Professor Dr. Sohail Sarwar to please come on stage and receive his award as a keynote speaker. Thank you, sir. Thank you so much, sir. I would now request Professor Dr. James Wolfson to please come on stage to receive his award as a keynote speaker. Thank you so much, Professor James, to come to us all the way from the UK. Thank you. Thank you so much, sir. I would request Professor Dr. Nasir Chaudhary to please come on stage and receive his award as a keynote speaker. Thank you so much, sir, for gracing with us with your presence today. Thank you so much, sir. I would request Dr. Zahid Awan to please come on stage and receive his award as one of the keynote speakers. Thank you so much, sir. Thank you. Thank you. I would request Dr. Mufarik Shah to please come on stage and receive his award as the keynote speaker for session 2. Thank you so much, sir. Thank you so much, sir. I would request Dr. Amir Ijaz Niazi to please come on stage to receive his award. Thank you so much, sir. Thank you so much, sir. I would request Dr. Asadullah to please come on stage and receive his award as keynote speaker. Thank you, sir. Thank you so much. I would request Dr. Adnan Khan to please come on stage for his award as speaker. Thank you so much, sir. I would now request Dr. Fatma Iqbal to please come on stage to receive her award as a keynote speaker. This is a moment of great pride for us because Fatma is an alumni of the University of Faisalabad. She is now in Sydney. She has done her PhD in optometry and now doing her postdoc. Thank you so much for coming and serving your institution again, Fatma. I would now request our collaborating partner, Barrett Hodson, to please come on stage. Mr. Ghulam Mushtaba, kindly receive your award. Thank you very much for your collaboration with the University of Faisalabad, sir. Thank you. I would now request the Rector, University of Faisalabad, Professor Dr. Mana Malik, to please give a token of our appreciation to the chair for the first session, Professor Dr. Asad Aslam Khan. Thank you, sir. Thank you very much, everyone, for joining us for the first contact session. The guests and delegates are directed to please join us for tea break in the courtyard area. And the students are requested to be seated here for a small activity. Thank you so much.
Students are requested to stay in the auditorium, please. And I request the ambassadors to stay on the doors. I request all the students to please stay in the auditorium.
Students are requested to please remain here, maintain discipline, and be within your seats. Kindly, all students, please remain seated. Thank you. Okay.
Hello, hello. Students are requested to stay in the auditorium. Assalamu alaikum, everyone. Assalamu alaikum, everyone. Please settle down. Please settle down. Thank you so much. Assalamu alaikum. How are you? Hopefully, every single person is doing super great. My name is Sumaya Bhatt. काफ़ी ज़्यादा presentations चल रही हैं. कल भी हम लोगों का एक session था oral presentation का. And I'm damn sure being a student हम लोग काफ़ी ज़्यादा थोड़ा बहुत bore हो जाते हैं, right? Yeah. मेक सेंस. ओके, सो हम लोगों ने ना एक सेशन प्लान किया है फॉर यू पीपल कि हम लोग इसके अंदर फॉर बेटर इंटरेक्शन हम लोग के आपस में एक दूसरे के साथ जस्ट टू रिलेट इट विद आवर फील्ड एज वेल. ठीक है, हम लोग का ये वाला सेशन बहुत मजे का होने वाला है. ओके, इस सेशन के अंदर हम लोग क्या करेंगे, हम लोग आप लोगों से भी कुछ पूछेंगे. ठीक है, एंड वी विल इंटरेक्ट अच्छे से. ठीक है, बट वी विल रिलेट इट विद आवर फील्ड एंड मायोपिया एज वेल. ठीक है, सो दिस सेशन इज अ क्वेश्चन एंड आंसर सेशन. ठीक है, जिसके अंदर हम लोग आप लोगों से क्वेश्चंस पूछेंगे. ओके, दिस इज बोरिंग राइट, क्वेश्चन पूछना इज सुपर बोरिंग. लेकिन हम लोगों ने इसके अंदर ये चीज की है कि हम लोग आपसे क्वेश्चन पूछेंगे, प्लस हम लोग जो आंसर करेगा सही उसको गिफ्ट हैम्पर भी देंगे. वी हैव गिफ्ट्स फॉर यू एज वेल. इंटरेस्टिंग, इंटरेस्टिंग. किसी को गिफ्ट्स नहीं चाहिए? गिफ्ट्स किसी को भी नहीं चाहिए वाकई में? ओके, चलिए फिर भी हम लोग प्रोसीड करते हैं आगे. ठीक है, नोबडी विल यूज गूगल, चैट जीपीटी वगैरह. ठीक है, हम लोगों के एम्बेसडर यहाँ पर है. दे विल लुक आफ्टर यू. प्लीज एम्बेसडर बी अटेंटिव. कोई फोन नहीं यूज करेगा पीछे से. बॉयज भी नहीं फोन वगैरह यूज करेंगे, चैट जीपीटी वगैरह कुछ भी नहीं. ठीक है, जस्ट यूज योर माइंड. बहुत ज्यादा बेसिक क्वेश्चंस है. अगर किसी ने सेशंस हम लोगों के पीछे वाले अच्छे से सुने हैं, सुने मैंने भी नहीं सुने, लेकिन फिर भी कोई बात नहीं, हम लोग वी विल ट्राई टू आंसर इट. ठीक है, ठीक है. ओके, आई वॉन्ट द एक्टिव इन्वॉल्वमेंट हर किसी की. ठीक है, पीछे से भी आगे से भी 10, 8 सेमेस्टर, 4, 5 और जो बाकी यूनिवर्सिटी से भी आए हैं. ओके, हम लोग फर्स्ट क्वेश्चन की तरफ मूव फॉरवर्ड करें. ठीक है, ओके, आप लोगों ने अच्छे से सुनना है. प्लीज चैट जीपीटी और गूगल यूज नहीं होना चाहिए. What are the main environmental factors that contribute to the development of myopia? अच्छा, क्वेश्चन अब ये है, प्लीज सेटल डाउन एवरीवन. इन्वायरमेंटल कौन से ऐसे फैक्टर्स होते हैं जिसकी वजह से मायोपिया आजकल डेवलप हो रहा है? आप लोगों ने हैंड रेज करना है जिसको भी आंसर आता हो. ओके, वी हैव 1, 2, 3, 4. ओके, पीछे से बॉयज में से किसी को नहीं आता? नो. ओके, एक एक हाथ खड़ा हुआ है. ओके, वी हैव 5 पार्टिसिपेंट्स जो आंसर करना चाहते हैं. ओके, सो लेट्स जस्ट स्टार्ट विद द गर्ल्स. लेडीज फर्स्ट, आप रुचिरा माइक. प्लीज स्टैंड अप. ओके, यू हैव टू आंसर 5 एनवायरमेंटल फैक्टर्स जिसकी वजह से हमारा मायोपिया जो है ना इंक्रीज हो रहा है. 5 या फिर जितने आपको आते हैं. ओके,
Excessive use of mobile phone.
थोड़ा सा ऊंची बोलिए.
Excessive use of mobile phone.
ओके, 1. ओके, ठीक है.
लेस यूज ऑफ सनलाइट, हम सनलाइट का एक्सपोजर कम कर रहे हैं।
सनलाइट का एक्सपोजर हम लोग क्या कर रहे
कम
हैं?
कर रहे हैं।
कम कर रहे हैं, ओके।
और
ओके, सेटल डाउन। अब
जेनेटिक
कोई
फैक्टर
नेक्स्ट
भी है।
कोई नेक्स्ट आंसर करना चाहता है? पीछे बॉयज में से तीसरा, बॉयज में से किसी एक को माइक दो। एंड पीछे एक लड़की भी है, वो भी बहुत विलिंगली आंसर करना चाह रही है, आपकी तरफ भी माइक आएगा।
ईयर वर्क।
और लॉन्ग नियर वर्क, ओके। और
ये बहुत
जो सबसे अच्छा आंसर करेगा ना उसको गिफ्ट हैम्पर मिलेगा, ठीक है? आपने एक आंसर किया है, आपने, ओके। और क्या हो सकता है? फॉर लॉन्ग नियर वर्क हो गया। और
तो क्या
एनीवन फ्रॉम द बॉयज? किसी को नहीं आता? पढ़ के नहीं आए?
ये माइक पीछे था।
जी तो हो रहा है।
नीड वर्क के साथ साथ हमने आउटडोर एक्टिविटी भी रिड्यूस कर दी है।
प्लीज फिर से बोलिएगा।
लॉन्ग नियर वर्क तो एक है कंट्रीब्यूटिंग फैक्टर, लेकिन उसके साथ साथ स्पेशली स्कूल उन्होंने आउटडोर एक्टिविटी है वो भी रिड्यूस कर दी। जब उसका स्टिमुलस कम मिलेगा तो ऑब्वियसली एक्साइटेडनेस जो कॉन्सर्ट जल्दी ही होगा।
ओके, सो आपका एक आंसर है कि एक्सेसिव नियर वर्क, उसके अलावा बस, उसके अलावा आपने क्या बोला है? एक्सपोजर टू लाइट, ओके। सो आई बिलीव कि जो सबसे अच्छा आंसर था ना वो आपका था। आपका नाम क्या है? मोहसिन। मोहसिन, ओके। एक गिफ्ट हैम्पर मिल गया मोहसिन को, तो मोहसिन के लिए जोरदार तालियां हो जाए। ओके ओके, अब आगे वाला जो सेशन है ना वो और ज्यादा इंटरेस्टिंग होगा, ठीक है? वी आर मेकिंग इट मोर इंटरेस्टिंग, ठीक है? यू गाइस आर हैविंग फन? थोड़ा सा, थोड़ा सा, कम ऑन, वी विल हैव फन, ओके? ओके, अब मुझे आप में से ये बताएं, ओके इस तरफ से भी हम आ जाते हैं, इस तरफ काफी ज्यादा हो गए। अब आप लोग मुझे ये बताएं कि कौन से ऐसे जेनेटिक फैक्टर्स होते हैं जिसकी वजह से मायोपिया की प्रोग्रेशन होती है? वी आर टॉकिंग अबाउट मायोपिया, राइट? तो जेनेटिक फैक्टर्स ऐसे कौन से हैं, बहुत बेसिक क्वेश्चन है, जिसकी वजह से मायोपिया होता है? एनीवन? जिन्होंने पहले आंसर कर दिया उसको नहीं मिलेगा, उनको दोबारा से चांस नहीं मिलेगा, ओके?
जिनकी मायोपिया की फैमिली हिस्ट्री होती है।
ओके, और फैमिली हिस्ट्री इज द वन आंसर, और
कजिन मैरिजेस।
cousin marriages, yes, that's true. Even though we don't like cousin marriages, लेकिन still, होता है। So, आपका नेम क्या है?
लुब्बा शाहिद।
ओके, आपको भी एक गिफ्ट हैम्पर मिलेगा, ओके? आप मेरी बात सुन ले अब, तालियां बजाएं, कम ऑन गाइस। ओके, अब मेरी बात सुने। पांच पांच गिफ्ट हैम्पर्स हैं हम लोगों के पास। दो जो है हम लोगों ने ऑलरेडी दे दिए हुए हैं, ठीक है? आप लोगों के पास तीन और का चांस है, ठीक है? सो यू गाइस नीड टू इंटरेक्ट, वी आर हियर टू इंटरेक्ट, ठीक है? आपको अच्छा आंसर आता है, बुरा आंसर आता है, आपने जस्ट आंसर करना है, ओके? ठीक है, वी आर मूविंग फॉरवर्ड टू द नेक्स्ट क्वेश्चन। ओके, दिस इज वेरी इजी, ठीक है? बहुत ज्यादा इजी होता है, और जो सबसे पहले हाथ उठाएगा ना वो आंसर करेगा, ठीक है? ओके, फोर्थ सेमेस्टर में भी इसे कर सकते हैं क्योंकि इट्स वेरी बेसिक क्वेश्चन। मुझे आप लोगों ने कोई 3 से 4 ट्रीटमेंट ऑप्शंस बताने हैं मायोपिया के। वी हैव आयशा आसिम। आयशा आसिम, प्लीज आयशा आसिम को माइक दें।
आयशा
4 होने चाहिए, वो भी एक्यूरेट होने चाहिए। ओके गाइस, आयशा आसिम बहुत अच्छा आंसर करने वाली है, लेट्स जस्ट सी। ओके आयशा।
सबसे पहले तो रिफ्लेक्शन करेंगे, उसके अकॉर्डिंग स्पेक्टेकल्स।
स्पेक्टिकल्स 1, ओके।
कॉन्टैक्ट लेंस।
कॉन्टैक्ट लेंस 2।
सर्जरी, लेसिक और लेसिक।
ओके, सर्जरी, बट ओके ठीक है। और
ऑर्थोकेराटोलॉजी।
यस, और
डाइट प्लान्स आल्सो।
ओके आयशा, यू हैव डन सच अ ग्रेट। आयशा के लिए तालियां हो जाए, चलें। ये बॉयज की तरफ जा रहे हैं, किधर जा रहे हैं? आगे को आ रहे हैं, ठीक है, ताकि अच्छे से सुनाई दे सके। ओके ठीक है, गुड। ओके, अच्छा अब हम लोग बॉयज की तरफ आएंगे क्योंकि बॉयज में से कोई भी आंसर नहीं कर रहा है। दिस इज नॉट फन, ठीक है? यू गाइस नीड टू इंटरेक्ट, ठीक है? आसान क्वेश्चन चाहिए। अच्छा, ऑडियंस में से आवाज आई है कि आप आसान क्वेश्चन नहीं करें, हम आंसर कैसे करें? थोड़ा सा आसान की तरफ चलते हैं। अच्छा, अब आप लोगों ने मुझे ये बताना है इसमें ये आंसर जो है ना ये बॉयज में से करेंगे गर्ल्स नहीं करेंगे क्योंकि लड़कों में से अब तक एक भी निकम्मा नहीं उठा ठीक है यू गाइस नीड टू इन्वॉल्व अच्छे से वी आर हियर टू इंटरेक्ट ठीक है अब आपने मुझे ये बताना है कि मायोपिया का लॉन्ग टर्म इफेक्ट बॉडी के ऊपर क्या क्या होता है मायोपिया का इफेक्ट क्या होता है पूरी बॉडी के ऊपर ओवरऑल नो गाइस प्लीज पीछे से देखे कोई गूगल का ना यूज करे लड़के बहुत चीटिंग करते हैं ये लेंस नहीं आ रहा है चलिए लेट्स जस्ट मेक इट मोर इजी अच्छा ये सबसे इजी है ये सबसे इजी है गाइस बहुत ज्यादा बेसिक है बॉयज ये बहुत ज्यादा बेसिक है ठीक है आप लोगों ने मुझे बताना है नहीं अभी नहीं वेट नेक्स्ट क्वेश्चन हम लोग का ये है और ये बॉयज में से आई रियली वांट द गाइस टू विन गाइस कम ऑन इतना बुरा नहीं है इतने अच्छा हम लोग बुरे नहीं इवन तो हम लोग का गर्ल्स कैंपस है लेकिन आई रियली वांट यू गाइस टू विन ठीक है आप लोगों ने मुझे ये बताना है कि एक्सियल लेंथ का क्या फैक्टर क्या क्या रोल होता है मायोपिया के अंदर इफेक्ट आता है एक्सियल लेंथ का ओके एक ने हाथ खड़ा किया है एक्सियल लेंथ क्या होती है मायोपिया के अंदर गाइस किसी को भी नहीं आता एक्सियल लेंथ क्या होती है मायोपिया के अंदर ओके वी हैव वन गाय 2 3 1 2 2 ओके युसरा माइक दे दो नो अभी सिर्फ गाइस से हमने पूछना है गो
मेरी बारी है चले
पहले सलाम करो
एक्सियल लेंथ बड़ी होती है बढ़ जाती है इंक्रीज कर जाती है
अच्छा इसके लिए तालियां हो जाए प्लीज प्लीज ओके आई रियली अप्रिशिएट कि आपने लाइक आंसर किया है इसको एक्सीलेंट बड़ी होती है मतलब उनका मतलब था कि वो उसकी लेंथ ज्यादा होती है सो आपको मिलेगा एक और गिफ्ट हैम्पर इनके लिए फिर से ताली होनी चाहिए क्योंकि एक्सीलेंट बड़ी होती है मूविंग फॉरवर्ड वी आर हैविंग फन थोड़ा सा नो ठीक है कोई बात नहीं हम लोग के पास आगे एक और सेशन है वी आर गोइंग टू बी हैविंग फन इतनी मुश्किल क्वेश्चन है मेरी समझ नहीं आ रही कि ऑडियंस कैसे जवाब देगी अच्छा हम सब लोगों को पता है ना सफेद मोतिया और काले मोतिया का थैंक गॉड अल्लाह का शुक्र है ठीक है सो ग्लाकोमा क्या होता है उर्दू में इसको क्या कहते हैं काला मोतिया कैटरैक्ट को सफेद क्योंकि आई एम मेकिंग इट मोर इजी फॉर यू पीपल क्योंकि वहां पे बहुत मुश्किल अल्फाज में लिखा हुआ है ठीक है अब आप लोगों ने मुझे ये बताना है कि सिंस वी आर टॉकिंग अबाउट मायोपिया राइट तो आप लोगों ने मुझे बताना है कि मायोपिया की वजह से ग्लाकोमा के ऊपर क्या इफेक्ट होता है नो सोचे 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 देखिए इट इज मेरी बात सुने इट इज रिलेटेड टू एक्सियल लेंथ एंड आईओपी अब मैं आप लोगों ने मुझे बताना है कि ये कैसे इफेक्ट हो रहा है नो आयशा यू हैव ऑलरेडी वॉन द गिफ्ट हैम्पर इस तरफ से आप इनको माइक दे इस तरफ ग्लाकोमा के ऊपर क्या इफेक्ट आता है मायोपिया का इसके इसके 3 आंसर्स है
एक्सियल लेंथ ज्यादा होने की वजह से हमारे पास
एवरीवन प्लीज 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 इतना डिस्कस करें लेकिन थोड़ा आहिस्ता
एक्सियल लेंथ ज्यादा होने की वजह से हमारे पास एंगल ब्लॉक हो जाता है जिसकी वजह से आईओपी इंक्रीज होता है एंड इट लीड्स टू ग्लाकोमा
ओके राइट आंसर तो आपको भी गिफ्ट हैम्पर मिल गया प्लीज इनके लिए तालियां हो जाए ठीक है हम लोग के कितने गिफ्ट्स डिस्ट्रीब्यूट हो चुकी है 4 नो 4 अभी तक सिर्फ 4 हुए हैं ठीक है आप जो नेक्स्ट क्वेश्चन मैं पूछ रही हूँ ना वो गिफ्ट के लिए नहीं है वो ऐसे ही है फॉर जर्नल ठीक है तो आप लोगों ने इसके आंसर करना है अच्छा ये बहुत अच्छा क्वेश्चन है बहुत मजे का है आप दे दो ठीक है यहाँ पीछे से इस तरफ पीछे से यू गाइज आर नॉट इंटरेक्टिंग वी आर हेयर टू इंटरेक्ट आप भी थोड़ा सा इंटरेक्ट करें यहाँ पीछे से एंड हम लोग की दूसरी यूनिवर्सिटी से भी काफी स्टूडेंट्स आए हैं कौन कौन से स्टूडेंट्स हैं जो दूसरी यूनिवर्सिटी से आए हैं आई मीन कैंपस से नहीं यस ओके बस इतने आए हैं ठीक है ओके अब हम लोग आप लोगों की तरफ भी आएंगे ठीक है चलिए, हम लोग का जो नेक्स्ट क्वेश्चन है ना, वो हम लोग का ये है कि हम लोग मायोपिया की बात करें। अच्छा, मायोपिया होता क्या है? मुझे आसान उर्दू भाषा के अंदर बताएं कि व्हाट इज मायोपिया। नो, नॉट नियर साइटेड, मुझे आसान बताएं कि लेमैन को हम कैसे बताएंगे मायोपिया क्या है। कोई एक खड़े होके अच्छे से बताए। एक मिनट, इस तरफ से पीछे से यू गाइस आर नॉट इंटरेक्टिंग, क्या हो गया है? यहां से मुझे कोई उठ के बताए व्हाट इज मायोपिया। व्हाट इज माई, इनको सबको आप आसान लफ्ज में बताएं कि हम लोग काफी देर से कल भी खप रहे हैं मायोपिया मायोपिया मायोपिया, आज भी हम लोग खप रहे हैं मायोपिया। व्हाट इज मायोपिया?
उसमें नजदीक की नजर मतलब कि ठीक होती है और दूर में हमें गलत साफ नजर नहीं आता, और इमेज रेटिना से आगे बनती है।
वेल, गुड गुड गुड।
इमेज रेटिना से आगे बनती है और हमें दूर की नजर सही नजर नहीं आती।
ओके, बैठ जाए, वेरी गुड। तो इन्होंने काफी अच्छा आंसर दिया है। मैंने स्पेशली ये लड़कों के लिए बताया कि उनको शायद ना पता हो मायोपिया क्या होता है। मायोपिया ये होता है जिसमें हम लोग सॉरी गाइस, आई एम सॉरी, मेरा रोस्टिंग मोड ऑन हुआ है, मुझे गुस्सा आया हुआ है, इस वजह से मुझे थोड़ा रोस्टिंग, प्लीज सॉरी, आई एम सॉरी गाइस, वी आर हियर टू लाइक एंटरटेन यू पीपल। ओके, एनीवेज, मायोपिया हम लोगों ने पता किया कि दूर के अंदर मुझे दूर से नजर नहीं आ रहा। बाय द वे, आई एम मायोपिक, ठीक है, मुझे दूर में नजर नहीं आता, इवन तो आई एम नॉट वेयरिंग ग्लासेस, ठीक है। तो दूर पे नजर नहीं आता और नजदीक पे नजर क्लियर आता है, ठीक है, तो दिस इज मायोपिया, ठीक है। अब आप लोगों ने मुझे ये बताना है कि हम लोग मायोपिया कितनी बात कर रहे हैं। मुझे आप लोग ये बताएं कि अब हम लोगों ने ग्लासेस भी दे दी, कॉन्टैक्ट लेंसेज भी दे दिए, लोग सर्जरीज भी करवा रहे हैं लासिक वगैरह ना मायोपिया के लिए, लेकिन हम लोग फ्यूचर के लिए इसको और बेहतर कैसे बना सकते हैं? किस तरह की ट्रीटमेंट हम दे सकते हैं? अपना अपने आप को थोड़ा सा आउट ऑफ बबल से जाके सोचो कि हमें और क्या करना चाहिए, दुनिया में इतना कुछ हो रहा है। इधर से कोई, किसी को भी नहीं पता, कोई कुछ सोचे ना कि क्या होना चाहिए। आपने पहले आंसर कर दिया हुआ है। इस तरफ से हाथ उठा है पीछे, युसरा, माइक देना उनको, मुश्किल से लड़के ने हाथ उठा लिया, प्लीज उनको माइक दे। तो आता हुआ ना फौरन घुट के बोल देंगे। ठीक है ना, ओके, ठीक है। अच्छा, आपने आंसर करना था, किसने हाथ उठाया था? प्लीज आप उठ के आंसर कर सकते हैं। चलिए आप बैठ के कर लें, आप थक गए होंगे काफी।
अच्छा, मायोपिया की जो प्रोग्रेशन है उसको स्लो करने के लिए एट्रोपिन ड्रॉप्स जो है वीकली जो है इंस्टिल करते हैं।
हाँ जी, ठीक है। और कुछ?
और इसके अलावा जो है आजकल कॉन्टैक्ट लेंस के अंदर जो है एक वो मायोडेस्ट ऑप्शन आता है, वो भी जो है प्रोग्रेसिव जो मायोपिया है उसको कंट्रोल करने के लिए यूज हो रहा है।
ओके, तो हमें इन्होंने, सर ने काफी अच्छा आंसर बताया कि हम लोग एट्रोपिन, गाइस उनके लिए तालियां तो बजाए, इतना अच्छे से उन्होंने बताया। वी रियली अप्रिशिएट यू, ठीक है। अच्छा अच्छा, मेरी बात सुने, काफी ज्यादा क्वेश्चनिंग होगी, थक गए होंगे आप लोग, नहीं है ना? चलो रोटी की बात करते हैं थोड़ी सी, ठीक है, खाना कब मिलेगा? भूख लग रही है, सुबह से हम लोग खा के नहीं आए कि हम लोग को कॉन्फ्रेंस पे खाना मिलना है, ये हम पाकिस्तानी है, ठीक है। एनीवेज, लॉन्ग स्टोरी शॉर्ट, जो अमीन कैंपस के स्टूडेंट्स हैं, इनका जो कूपन है खाने का, ठीक है, वो मैम लारेब के पास होगा, तो आप लोगों ने बिल्कुल परेशानी होना, उफ अल्लाह हम सलीम कैंपस आ गए, खाना कूपन की तरह, फाइल्स की तरह, हमें कुछ भी नहीं मिल रहा, कोई अच्छे से गाइड भी नहीं कर रहा, तो आपने बिल्कुल भी परेशान नहीं होना, वी आर हियर टू फैसिलिटेट यू। आपने मैम लारेब, आप लोगों को पता है ना कौन है भला वो मैम लारेब? पता है ना? आपने उनके पास जाना, उनके पास फाइल होगी, फाइल के अंदर कूपन होगा, एंड उससे आपको रोटी खुल गई, ठीक है, मिल जाएगी, रोटी वगैरह मिल जाएगी, ठीक है। एंड हम लोग की जो अपनी सलीम कैंपस की गर्ल्स हैं, आप लोगों की जो फाइल्स एंड कॉपन है ना, वो आपकी अपनी अपनी सीआर के पास है, प्लीज बहुत ज्यादा chaotic सिचुएशन नहीं आपने बनानी है, जस्ट कॉल योर सीआर एक जगह पर, आपको आपकी जो टीचर्स है वो आपको प्रोवाइड कर देंगी, ठीक है। आप लोगों ने बिल्कुल भी परेशान, आप घबराना नहीं है, ठीक है ना? ऑलराइट, मूविंग फॉरवर्ड। अच्छा, हम लोगों का कितने रहते हैं? हम लोग का एक गिफ्ट टाइम पर रहता है, राइट? एक गिफ्ट टाइम पर रहता है गाइस, ये गिफ्ट बहुत अच्छा है, आप लोग हमेशा याद रखोगे। आपको टी भी मिलेगी, खाना भी मिलेगा, सारा कुछ मिलेगा। अच्छा मुझे बताएं, अब एक और क्वेश्चन है, ठीक है? यहाँ जो पीछे बैठे हैं, फोर्थ सेमेस्टर है ये, इस तरफ। यू गाइस आर नॉट इंटरैक्टिंग, क्या मसला है? 4 है, कोई बात नहीं, यू गाइस नीड टू लाइक थोड़ा सा एक्टिव हो जाए। हम्म। अभी वेट कर, ठीक है? All right, we are resuming our session. Thank you so much for your active collaboration. Guys, we are back. We are back. अच्छा मुझे ये बताएं कि कोई पोस्टर प्रेजेंटेशन की वो जो हो रही है, कंपटीशन हो रहा है, उसमें कोई है यहाँ पे? कोई भी नहीं है? मिनाहिल, मिनाहिल, अदील, मिनाहिल, अदील, आदिल, चली गई है वो, ठीक है? ओके, अच्छा मैं जाऊँ।
Ladies and gentlemen, please be quiet so that we can start the session. All right. Girls, please, girls at the back, can you please be seated? Ladies and gentlemen, esteemed colleagues and honorable guests, welcome back to the second scientific session of the day. We are delighted to continue exploring the fascinating world of myopia research, a topic that has garnered significant attention in recent years due to the increasing prevalence and impact on global health. We look forward to the insightful presentations and discussions that will follow as we work together to pave the way for innovative solutions in myopia research. So as we are transitioning into the second session, it is my pleasure to request our chief guest of the event, Professor Dr. James Wolfson, to chair this session. Professor James needs no introduction, has already been introduced. So please join me in requesting Professor James to come and take the chair of session. I've got something to write for you. Now, it is my great pleasure to invite Ms. Aisha Salim to join Mr. James Wolfson as a co-chair of this session. Ms. Aisha is a senior optometrist and the current president of Society of Optometry, Orthoptics, and Technologists, and she has a decade over experience in optometry. Please join me in welcoming Ms. Aisha Salim to the stage. To formally start this session, I would like to invite the first keynote speaker of the day, Dr. Zahid Awan. Dr. Zahid Awan is a famous personality. He is currently working as a project manager in CBM International and is a passionate advocate for vision and inclusive eye health. Please, Professor Zahid Awan, Dr. Zahid Awan, take the stage for your insights.
स्टार्ट करो
Yes, yes, please.
बिस्मिल्लाह रहमान रहीम नहीं चल रहा बिस्मिल्लाह रहमान रहीम I am Dr. Zahid Awan, working in CBM. CBM since last 10 years, and by training I am an ophthalmologist and looking after the eye care portfolio of Pakistan within CBM. Today's topic is, I was asked to speak on myopia. So we are not a curative people, but we are a preventive people. We would like to tell the students that you are all a preventive ophthalmologist in future. So what we are going to do that you can opt, you can see how we are going to detect myopia in the field without higher technologies. This is the agenda of my presentation. I will talk about CBM, I will talk about PEAK, and how as a district model for PEAK, and role of optometrist that you people are and somebody is going to be. and screening data till to date, district-wise breakup of myopia, and impact of optometry clinics on detecting myopia and also reducing the burden of secondary eye care services. And 2030 Insight, lesson learned, conclusion, and our partners who are part of our journey during the last few years. The CBM is a Christopher Blinden mission. It is an international development organization based in Germany. We are working more than 30 to 35 countries across the globe. And we are working in Pakistan since 1968. Our major focus was eye health. Our mission is to develop an inclusive world in which all the persons with disabilities enjoy their right and achieve their full potential. But our major focus is eye care. Our three major aims of working in across the globe is aim to provide comprehensive, inclusive eye care services, inclusion made in eye health programs, and system strengthening approach. You will see the system strengthening steps that we have taken up since last couple of years in terms of eye health in Pakistan. CBM is a long-standing partner of National Committee for Eye Health, and we are presiding IAPB, International Agency for Prevention of Blindness, ICO, and number of organizations in the world. PEAK, everybody is aware. I think most of the students are aware because now PEAK is a very hot subject for everyone, particularly for the preventive ophthalmologist and organization across Pakistan. It is a smartphone-based vision screening, real-time data reporting and analysis. PEAK PEAK is a capture or a IT structure, not a big deal, but all the things are being done by the government of Pakistan. It is a data collection method, and that data is collected, analyzed from communities to the tertiary centers, a paperless activity that we are working in Pakistan. It's a very interesting district model, and you can see where you are going to fit into the health systems. Optometrist is the backbone and a pillar of prevention of blindness across the world, wherever you are working. And in Pakistani health infrastructure or a pyramid, your work starts from primary, secondary, and tertiary. Primary is the major focus. Currently in Pakistan, so very less, and you can say that ignored area, that at rural health center still there are not positions of optometrists are still being created. But in the province of Sindh and Balochistan, they have created, but unfortunately not in Punjab. Punjab is only limited, their eye care services are limited to the secondary hospital, that is Tehsil headquarter hospitals, but not to the primary. Our project where we utilize optometrists by establishing optometry clinics at rural health centers, and all the patients from the communities and the basic health units are being screened and referred for the triage at rural health centers. And from there, patients are being referred for dispensing optics and further sophisticated investigations at secondary hospitals. If not available, then at the tertiary hospitals. And the major thing that comprehensive eye care model includes is optical shops. Currently, CBM has started more than 10 to 15 optical shops. Those are linked with the PEAK. And wherever you are seeing mobile devices, these are linked to Android, to internet, and all the data is collected in the clouds, and where the analysis is being done by PEAK and also the London School of Hygiene and Tropical Medicine. Role of optometrist. I think whenever we talk about any position or any cadre, we need to learn what is our role. Practically what we are means, I am also an ophthalmologist, and I have 30 years of experience in eye care across Pakistan and other countries. whenever we say that we are ophthalmologists, we are focused to one thing that, okay, we have to operate cataract, we have to operate retina. But we never thought about awareness. We never thought about that what we have to speak with the patient. There is an analysis in Peshawar when I was a student of masters in PICO. One of the consultant has done analysis on patient and a doctor conversation. That was milliseconds. That one doctor communicates, articulates with the patient in milliseconds, not a minute even. So this is the basic thing that we preventive ophthalmologists, we thought about. Role of optometrists is creating awareness about their hygiene, about their disease, and about the availability of services that where they are located. Not only where they have the clinic, where they have the optical shop, but also other facilities to define where they are located and where they can get the good services. Providing advanced primary eye care at rural health centers, this is their role. And most probably most of the people will be posted if government of Punjab is going to create the positions. And then providing rehabilitation services, a low vision, which is still an ignored topic in Pakistan. Only at the private clinics we are finding somewhere, but not in the public sector. And this is the biggest challenge that we are going to face in 2030 might be. Screening till to date by using PEAK, we have screened more than 5.5 million. This is data till 21st February. This is 2025, sorry. I missed to replace it. And these are the percentages that how many percentages are going to secondary, tertiary, and other areas. Myopia in children. If you see the last line from the prescriptions, we found that 85.84% of the children are suffering with myopia. This is a real-time data that is available in the software. This is not that data that is written on the papers and then it could be cooked like other forms we usually see, but this is a live data available in the cloud. And if you see that we have screened 1.6 million children, only 6.16 children needed the next level. Means 94% of the children, they could be treated at the primary level. And what parents do, they bring all the 100% to the tertiary hospitals. So this has created a mess in Pakistan. That's why the professors and other relevant academic people are much focused to service delivery rather than academics. And when we talk about adults, 30.6% is myopia. This is also a real data, and it's up today, means 21st February. This is the data that we have collected. And again, you see that 90% of the diseases and the eye ailments could be treated at primary level because 3.9 million were screened, only 10.7% who need to be shifted or referred to the next level. We are working in 7 districts in Pakistan, and you can see the burden of myopia in each district. If it is not clear, I can share because my presentation is with the colleagues. So you can take this presentation, you can approach us, and you can see the live data. That this is the alarming situation that we are going to face in next few years. Chakwal is one of the most developed districts in Pakistan. If you see 97% child myopia, 97%. And this is a real data. When we talk about myopia and we are talking about the treatments, we are talking about the advancements. Yeah, this is also a need. But how many people need LASIK? How many people have money to go for the LASIK? Why we are not, means government or we as a preventive ophthalmologist and ophthalmologist or as students, why we are not thinking on this area that what should be the best solution, the affordable solution that institutes can provide. Impact of optometry clinics. You can see it's a dramatic change in Talagang, in Chakwal. We started our first program in 2018 with the PEAK and established optometry clinics. Optometry clinic is established between between primary, means basic health unit, and a secondary level. What we saw that before our intervention, 41% of the refractive errors were dealt by ophthalmologists at tehsil level. If anybody among the students know about the tehsil level, if you are going to become an optometrist, you must know what is the health infrastructure of Pakistan. 41.4%. And after 1 year, we again analyzed by establishing optometry clinics and deploying you at that center. Only 1% of the refractive errors were dealt by the ophthalmologist. This is the biggest difference that I usually present to the government officials as well, to the institutions as well. We can think about this. This is 2030 Insight. This is IAPB data that could be available on IAPB website, might be, or IAPB Atlas. Anybody can see, or might be at the London School of Hygiene, Tropical Medicine, and the Pakistan chapter. In 2020, we were 220 million, and blindness is 0.80, and the all vision loss is 11.60. Number of ophthalmologists in 2020 was 1,913, and we are expecting that today they are in 2025, they would be, or they are 2,448. And in 2030, 3,015. But still, per million, one is only 8.7 ophthalmologists are working for 1 million population in Pakistan. This is also an alarming situation. Means how we can treat, how we can claim that we have achieved the things that we are speaking about. How can we reach, how the persons can reach us. One ophthalmologist is sitting in a secondary hospital, how much patient he can see, how much he has the capacity. Or in a private setup, how much he has the capacity, 30 patients, 40 patients per day. So how can one ophthalmologist can deal? So there is a need of optometrists to get empowered. What we see that currently in 2020, only 824 optometrists were available in Pakistan, and this is IAPB data. I don't have the correct reference, but this is an IAPB data you can see. And in 2025, 2,100. And in 2030, this is assumption that 3,475 optometrists would be there. But still, optometrists are 3.7 at 1 million. We need at least 500 per million. Then we can say that this is the matter that we can have dealt with the eye care problems at the primary level, otherwise not. A number of ophthalmic technicians and allied ophthalmic personals. And our slogan is that we need to increase the fully skilled optometrists to be trained in the institutions. And they must get realized that they are being trained for primary level. They are not trained to go Sydney, they're not trained to go UK, but they should work here with us as well. As we people are working here, everybody in the preventive ophthalmology have got number of chances to go abroad, but still these things are being materialized. And we need to work and we need to think on this, that how we can serve our people who are in need. This is not for the private universities. Sorry to say, this is for the government, because we are partnering with the government of Pakistan, government of all the provincial governments. So we usually talk about them, that successful health system is strengthening to integrate eye care into primary health care. Otherwise, this is not possible. Professor Asad is struggling since last 20 to 20 or 30 years, he is struggling that there should be a creation of the positions for optometrists, but still he is not succeeded to trickle them down to the rural health centers, but only at the secondary level. But still at secondary level, number of complications. They have introduced commissions, which is very difficult to pass for everyone. And for one tehsil of 2 million people, there is one optometrist they are posting. So this is not the solution actually. Enhanced community awareness, increased community accessibility and affordability, acceptability to the first level health facilities, improved affordability, demonstrated sustainability for service options to address uncorrected refractive errors and presbyopia. Presbyopia is everybody is aware that what is this? This is the natural thing that have to happen, but myopia and other reflective errors could be dealt at the primary level. Technology helped to optimize primary healthcare and CBM. Peak-powered programs supported districts in Pakistan, increasing access to specialist eye health for those who need it, and referral links. By virtue of introducing technology-enabled programs, the missing link was referral system. And now, if you have seen my slides, 90% of the referred cases are being received at the triage levels. So this is the biggest achievement of this technology. And the lesson learned that the take home must be that we should develop a system where no person should left behind, particularly who are referred to get to the next level. These are our partners, the Government of Pakistan, Sindh Institute of Ophthalmology and Allied Vision Sciences, Hyderabad, College of Ophthalmology, LRBT, and a number of other organizations we are working, Al Ibrahim Eye Hospital. And also we have peer organizations like Sight Savers, Fred Hellows. We jointly, and Brian Holden Vision, we are jointly working to support the governmental systems to reach to the unreached who really need it. Thank you.
Thank you so much, Dr. Zahid Awan Saab. Now, our second speaker of the day is Dr. Adnan Khan. He is our senior and one of the pioneer doctorates in optometry from Australia, and he's also a research fellow from Weill Cornell Institute, USA. Currently, he is serving Heber Medical University, and today he'll share his insights about some of his research findings on myopia. Please join me in welcoming Dr. Adnan Khan on stage.
Thank you so much, Dr. Memuna, for inviting me to this conference. And I would like to say welcome to all of you, the international guests, the national, and all the dear students. Today, I'm going to talk about peripheral refraction and myopia control, bridging the theory to the practice. So this was the work that was done when I was a PhD student along in my lab. I'm going to share you the other lab mates. So the overview of the talk for today will be get an overview of myopia control options, understand peripheral refraction concept, how theory can help patient in real time myopia management, and impact guidelines. So in the science, translational research is very important. And it has been published, this picture, in 2008 in Nature. So we can see that the scientists do the work, but it's very difficult to translate them to the clinical practice. So they have shown that it's a death valley because most of the clinical trials are failed. So we can't translate the basic research done in the labs to the clinical practice. And NIH and people in the real world are worried about of translating medicine. I'm educating around the developing countries, and especially in our students, that how to do the basic research and how we can translate them in our real life. So that's I am the educator for that. So here you can see my lab, GEMS. You might see some of the faces you are familiar, apart from the couple of them. David Atchison, one of the great human and great scientist in visions Ed back in 2014. Pawan is over here, and Ankit, and you might don't know this guy. So this is the lab that we were doing on most of the optics work, and David has done a lot of good works. Early peripheral refraction and myopia and aberrations back in, I think it started from 2004, and did some pioneer study along with other groups in the world. And he's mostly involved in the aberration and peripheral refractions. So what we knew about myopia was usually when we were a student, even like myopia, we were thinking of just a single vision corrections. But later on, but that's the problem as well, because if we can see in the world, the myopia increasing as alarming rate, especially in East Asia. We can see that there are 2.5 billion people with myopia currently, and they're expected to increase to 5 billion. But the most important thing is that we are going to see the high myopia as well, which is 1 billion people expected in 2050. Slowing the myopia progression by 1 diopters during the childhood lowered the risk of 40% maculopathy. So the biggest issue with the myopia is the maculopathy that's cause the blindness. And the most dangerous one is the early onset myopia. How we can control the myopia? So we can control by orthokeratology, by center distant multiple focal contact lenses, peripheral defocus, spectacles, bifocal progressive addition lenses, and lifestyle modification. And now we have the pharmacological treatment as well, low dose atropine and light therapy as well. So these were the strategies to control the myopia. But where are the site of actions? Those are the accommodations, receptor structures, peripheral contrast, light and nerve work, and peripheral defocus. Our main topic of discussion for today is the peripheral defocus, how we are going to do the peripheral refraction and correct them, and how the peripheral defocus is contributing into the myopia. So what's new in the myopia? The optical myopia management's efficacy is by literature shows it's from 50 to 70%. And now in the market, we have myopia peripheral defocus correcting myopia glasses, and a lot of options over here. So we have got the Myo Visions, Myo Smart, and Hoya, SLR, Stateless, orthokeratology, Noya. So these are the available options to correct the peripheral defocus in the myopia. Why myopia peripheral retina is important? Frankly speaking, when we were doing that, me with the our lab mates, and mostly the Pawan was involved a lot in the myopia peripheral refractions work. So in the labs, we were always chatting, is it working? Is it really working? So, but we were doing the research. Okay, so we had the theoretical knowledge in our minds, and we were applying that, and we want to translate that. So visual signals from fovea may not be essential for ocular growth. So that has been shown from the animal experiments, mostly on monkeys, poor monkeys. Animal experiments. It has been shown by Smith et al. That effect of foveal ablation on ametropization and form deprivation myopia. We can see the normal one, and this is the ablated one. The fovea has been removed. And this is the data that it shows. This is the control with the lines, and the treated eyes for the monkeys with the black circles, and the fellow eyes were the untreated eyes. So we can see that even after ablation and form deprivations, there peripheral myopia were there as compared to the control. So the next question, the eye elongated even after optic nerve section. So it has been, it's available in the literature, even if you remove the optic nerve, the peripheral retina, and the eye elongate without even the optic nerve. So what is peripheral refraction? Well, mostly we have dealt with the central refraction at the fovea. But what is peripheral refraction? When the refractions, when the light focus beyond 20 degree of visual fields in the periphery, that's called the peripheral refractions. Like this. Like this. This is myopic eye. This is their peripheral refraction. You can see now what is peripheral refractions and relative refractions. So we can see over here myopia and in periphery hyperopia. So it's a relative peripheral hyperopia, and that's the most important in myopia, progressive myopia. Sorry. Here we can see it's a peripheral retinal myopia. It's a myopia at the centers, and that is due to periphery. In literature, if we look at the shape of the retina, we have done a lot of work in the labs on the shape of the retina using the lens star and then the MRI. And in the emmetropes, we can see the spherical shape of the retina. In hyperopes, this like that. This is the hyperope, peripheral hyperopia, and this is the central myopia. Here we can see peripheral hyperopia. That's the most important thing. So relative peripheral myopia, that's considered to be a risk factor for progressive myopia. And we quite don't know, but the prolate shape contribute a lot to the myopia progressions. So there is a literature available in the with respect to the peripheral retina. That's why the peripheral retina is important in the myopia progressions. So it has been documented the peripheral retina has neuron that are tuned for different orientation, and that it make use of different two astigmatic foci to recognize as a focal single to regulate the ocular growth. Because when the eye is going to elongate, so it's contributing to the myopia. And it has been shown that white children are more prone to short-term changes in the myopia. Oh, now that's the clinical trials, how this has been translated. So we have got the lenses that provides effective myopia control and is more effective in control for children with baseline hyperopia. Those who have the baseline hyperopia, these DEAMS lenses have been shown to be more effective in controlling the myopia. Orthokeratology, how we are going to correct the myopia with the orthokeratology? We are going to put the lens and it's going to correct the peripheral refractions, peripheral defocus. Second option is open field autorefractors. How we are going to use the method of the open field autorefractor for peripheral refractions? Usually, this one is the lens star, and usually we have this attachment accessory. So we were going to show different targets to the patients, and we're going to take the axial length of the patients over here. And here we're going to do the peripheral refractions horizontally and vertically. But what's the limitation for them? You need, to measure these peripheral refractions, we need large space. Can you see that? Wide field, wide space, and its cost as well. The Cochrane review, that's the, you can say, the tag mark, and Cochrane reviews are more very exhaustive work, and it's one of the finest work to work in the literatures. So that shows that the axial length during 2 years is decreased when you are going to use the orthokeratology contact lenses. And the site for intervention for these are the because you are going to prevent the light, you need to increase the light and lag of accommodations and peripheral defocus, peripheral contrast. So when we are going to start, if somebody has got like a myopia, when we are going to start, when we are going to correct, who is going to correct, how we are going to correct, and where we are going to correct. So it's the Pawan et al. Has done a comprehensive review, and they have established an impact guidelines how to manage myopia. So the first thing in the impact guidelines are to identify the axial myopia and the true one. So the myopia can be because of the, sometimes can be because of the cornea, rarely become because of the lenses as well. So we need to find out the axial myopia and map the risk factor for that. So what are the risk factors? So the most important in the literature nowadays, that you need to have the exposure to the sunlight. The most of the time you do the outdoor activities, you take the breaks between when you're going to look at the screens. So these are the risk factors. And yeah, parents as well. If your parents are myopic, so you have high chances of getting myopia. So, and pick the progressive myopia. We need to identify the patients who have the progressive myopia. Well, because it's going to increase yearly by yearly. If there is more than 0.5 diopter of myopia increasing every year, so it's considered to be progressive myopia. So we need to pick that, and we need to have the treatment for them. Advise appropriate control strategy for myopia. Now we have got, right now we were discussing about the peripheral defocus using the spectacles, contact lenses, orthokeratology, but we have got the light therapy as well as the pharmacological therapy as well. Consult, and combine and monitor regularly. We need to consult our patients and their parents as well. Specifically in the children below 5-7 years old, we need to consult with their parents. The importance of, even like if they are hyperopic, so they are going to progress. If it's mild hyperopic, they are going to progress to myopia, and the mild myopia are going to progress to high myopia. So there are greater chances of it. So we need to regularly monitoring it. It depends upon how much like if they are high risk, high myopia, so we need to look at them after every 6 months. But if they have mild myopia and you think that's not progressive a lot, so we can have a checkup have a visit to them after a year. And taper and cessation of myopia control strategy. So, and then we need to decide as well when we are going to cease the myopia, whether that will be useful for the children. For example, if you're going to go for pharmacological therapy, or you are going to go with the orthokeratology. So you need to have decide as well when you are going to stop for them as well, because if they are not working. And the most important thing that with these guidelines, we have now we have to do personalized treatment, personalized medicine. It's not the one type of treatment is not appropriate for all of the myopic patients. We need to have personalized it. Summary. Myopia control beyond single vision, we are going to do that. There are multiple options available right now. It's environmental, spectacle, contact lenses, pharmacologically, evolving rapidly. That's a holistic approach. And that's the impact guideline as well. Over here, we have, I just want to share our practical experience as well. Dr. Shah is over here. We are all the time for the last 20 years where I have been seeing the patients. It was all about the holistic approach. It was not fixed that we are going to, it's a patient has got that myopia and when we are going to stick with that. We were looking at them with different perspectives, each and everything, their axial length, their response to the treatment, their age. So it was all holistically, and the world is now coming up to the holistic approach as well. So we are going to treat each case case by case and manage them. So I'm educating for the translation medicine. So, and in translation medicine, we get the ideas in the lab. Okay, and then we are going to translate them in the real world. And that's risky as well. When I was working with David, he was working with myopia, and some of the even papers that we were following them, the literatures, and after 30 years, we came to know that those papers were not right even, and the things that we were doing for last 30 years, that was not right. But look, all the brave people, courageous people, they move forward and they take steps. So I truly appreciate Muhammad Ali quote. He who is not courageous enough to take risk will accomplish nothing in life. Thank you so much. Last thing I would like to mention, sorry, I didn't mention in the beginning, I have got some of the slides from Pawan. So I need to acknowledge him. That's, as a scientist, I need to do that. Yeah. Any question? Thank you.
Thank you so much, Dr. Adnan Khan, for your valuable insights. Now, the third speaker of the second scientific session is Dr. Mufarriq Shah. He needs no introduction. He is our teacher. And currently, he is working as head of optometry department at Pakistan Institute of Community Ophthalmology. Please join me in welcoming Dr. Mufarriq Shah on the stage. Thank you.
Auzubillahiminash-shaytanir-rajim. Bismillahir-rahmanir-rahim. So my topic is based on the research, and I concluded for you people that why myopia management is crucial for children. There are 13 facts based on the research. This is fact number 1, global prevalence. Now, East Asia is the hotspot for myopia. And unfortunately or fortunately, we are also living in Asia. If you see here, it ranges from 60 to So from 60 to 97%. And South Korea, it is 97%. In Africa, it is less. And in Pakistan, according to the National Blind Survey, it is 36.5%. So the global prevalence is much higher, and really we need to manage myopia. Fact number 2, it is not only the prevalence. Unfortunately, the prevalence is getting increased. And it has been expected that by 2050, 4.9 billion people will have myopia. That is, every second person in the society, they will have myopia. And 10% by 2050, they will have high myopia. The latest definition for high myopia is -5 according to a WHO and BHVI report. And they says that if myopia is -5 and uncorrected, then the person comes in the category of blindness. So that is why they changed the definition of high myopia from -6 to -5. Fact number 3, high risk of sight threatening. No, myopic macular degeneration, retinal detachment, posterior subcapsular tear, and glaucoma. These are the major risk factors of high myopia. So that is why we need. Sight threatening complications. If a patient has -1 to -2.99 myopia, then he has 2.2 times risk to have macular degeneration. But if the myopia is -9 diopter, so he has 348 times more risk of getting myopic macular degeneration. Similarly, if the myopia is -0.75 to -2.75, so as compared to normal person, that myopic patient will have 3.1 times risk of retinal detachment. But if it is -15, though the risk is exponentially increased to 88.2 times. Similarly, cataract, if it is -6 diopter myopia, then the risk of cataract increases to 5.5 times as compared to the normal person. So this is the fact that why we need to myopia management. Fact number 4, Pakistan is at high risk. This was my first research paper published in 2004 in American Journal. And at that time, the leading cause was myopic macular degeneration. No smartphone was not there at that time. The data was collected from 2000 to 2003. Smartphone was not there at that time. Internet access was not there at that time. So even at that time, the myopic macular degeneration was the leading cause of low vision among the low vision patients. Now you just think today, and after 20 years, the smartphone, the internet, the indoor activities, the indoor generation. So what will be the result? And if you see the most alarming thing, under 29 years of age, the major affecting age group is under 29. You see, while in other cases like diabetic retinopathy, in these, the major age group are 50 to 59 years age. But so these people, they will live for 35 years in blindness category. If he get low vision patient at the age of 30 years. So Pakistan is a high-risk country. Now, another research, it was published in 2011 College of Journal of Physician and Surgeon Pakistan. If you see here, the three main, in children, the major cause is nystagmus, Stargardt disease, and followed by myopic degeneration. So after the 18, it jumped to the top. All these three major, the leading causes, they are connected to genetics. And why? In this research, 40% of patients, they have positive consanguinity. That is, their parents were first cousin. And 37% of the children with these disease, they have at least one another sibling suffering from the same disease. So it means that the congenital factor, the trend of family marriages, the trend of cousin marriages is still high in Pakistan. And this burden is further exacerbated by the smartphone use and the indoor generation. So that is why this is fact that Asia, like Korea, China, the prevalence is high there. But I suspect that the prevalence of vision threatening condition, myopic macular degeneration, blindness due to macular degeneration, Pakistan is on the top. Fact number 5, each diopter matters. How? Suppose a patient, he will reach to minus 6.5 diopter. And what you did, you started myopia management, you stopped this. Instead of 6.5, we stopped it at minus 4.5 diopter. So what you did, you reduced the risk of myopic macular degeneration from 40.6 times to 9.7 times. You reduce the risk of retinal detachment from 1.5 times to 9 times, and you reduce the risk of cataract from 5.5 times to 3.1 times. So that is why each diopter matter. The global burden of myopia is growing. Now, overall, the current global cost estimate related to the direct health expenditure and loss of productivity are in billion. That is US 709 billion per year. This is in the age 12 to 17 years. While the health expenditure is greater in adults, reflecting the added cost due to myopia-related complications. No, in Pakistan, like how can they calculate? In our society, most of the time we are thinking about the cataract. Our seniors or ophthalmology, that cataract is a blinding disease. But economic burden is calculated on the basis of blind person year. What is blind person year? For example, a patient get blind due to cataract at the age of 60 years. Now suppose if in this hall we have 100 patients and they develop cataract at the age of 60 years. So they will go blind for 5 years. Life expectancy is 5 years. So how much is the blind person year? 500. If 100 patients among them, they are diabetic and getting blind from the diabetes, so what is the mean age of blindness for diabetes is 50 years. And the life expectancy for the diabetic patient is 60 years. So they will live 14 years. So what is the burden? 10 into 100, 1,000 blind person year. So the burden is calculated on this. But from the research, that the patient with myopic macular degeneration, they get blind at the age of 30 years. So if in this hall, 30 patients are blind due to myopic degeneration, for how long they will live blind? 35 years. So what is the blind person years? 3,500 blind person years. And we all know that quality of life is compromised with blindness. So if a person is living 35 years with blindness, then the psychological, the quality of life, these are the extra burden on the finances. There is no safe level for myopia. You might have seen some patient with 16 diopter myopia, they have 6/6 vision. But some patient with -6 and -7 diopter myopia, and they have myopic macular degeneration. So you cannot say that it is just -6 diopter, so go ahead. No, because there is no safe level. Fact number 8, myopia correction versus myopia management. Till now, like the practitioner, eye care practitioner, they were thinking if the parents bring child to them and he has myopia, -4 diopter, he was using the spectacle, just the eye care practitioner prescribed, no, it is -5.5, so you make the new glasses, the myopia is increased. If the parents were here, is there any treatment? They say no, there is no treatment, you just change the glasses. But no, myopia management is the standard treatment according to the WHO. So, risk factors. Now, what are the risk factors for myopia? There are 6 major risk factors based on the research. Age, if age is less than 7 years, refractive error, if less plus refraction than the expected for age, and parental myopia, if one parent is with myopic ethnicity, if East Asian, time spent outdoor is lesser than 1.5 hours, per day, and time spent on near work is more than 2.5 hours. So on the basis of these 6 risk factors, you can calculate the risk profile for the patient. Now, how will you calculate? If risk factor patient has 2 from the 6 mentioned risk factor, if it's 0 to 2, then there is low risk of developing myopia. If 3 to 4 risk factors are there, medium risk of developing myopia. And if 5 to 6 risk factors are there, then there is high risk of developing myopia. Now, if we are creating myopia profile for us, for our society, the high risk for myopia practitioner if a patient had 4 of the following. Because we are Asian already, we already have the 1 risk factor. So just we need 5 more, 4 more. If we have 4 more risk, then high risk. Axial versus myopic refractive error. If axial length is less than 26, then the risk for vision impairment due to myopia is 3.8%. If it is from 26 to less than 30 mm, then the risk is 25%. And if it is greater than 30 mm, then the risk of vision impairment due to myopia is 90%. Does myopia progression stop after age of 18? So 48% they stabilize by the 15 years and 52% progress beyond 15 years. 77% stabilize by the age of 18 years and 23% progress beyond the age of 18 years. 90% stabilize by the age of 21 years and 10% progress beyond 21 years. 6% progress even beyond 24 years. So you need monitor till that. Treating myopia is an investment. Financial investment and active myopia management during childhood may balance or exceed across the lifetime by reduced refractive progression, simple lenses, and reduced risk of pathology and vision loss. So if you are doing myopia management for children, you just tell that this is just investment, net expenditure. Myopia management market, no, it is a win-win situation. For patient, for parents, they are investing. For the practitioner, they are earning. For the industry, optical industry, contact lens industry, ortho, they are earning. So this is a win-win situation, myopia management. So myopia management is a win-win situation and everybody business. Everybody is getting benefit from it. Now, management, how will you, what is the aim of management myopia? To prevent progression of myopia to reach high myopia. What is progression of myopia is there is no myopic shift within an year, then means no progression. If the myopic shift is minus 0.25 to minus 0.75, then this is moderate progression. And if the myopic shift is more than 0.75 diopter, then this is a fast progression. Now, what are the myopia control options? Spectacles, exacto bifocal, progressive multifocal, peripheral defocal spectacles, different types as Adnan mentioned. Number 2, orthokeratology at first from -1 diopter to -6 diopter and low dose atropine 0.01% to 0.05%. As Adnan, to what we are doing, forget about what is theory, because if you are just spending time of theory, you will not be able to do anything. What are the simplest way and what our patient can afford? Like orthokeratology in our society, it is just theory. Why? Because for orthokeratology, you need to start within 24 hours, the patient should get lenses. And when I order the lenses, it takes 2 months. So it will not work up to 2 months. And too expensive, mostly our society, the people, they cannot afford this. So the simple thing, for myopia management, there's 2 mechanisms. One is the choroidal technique, that is pharmacological, and the other is peripheral defocus. As Dr. Adnan already mentioned detail about the peripheral defocus. So for the peripheral defocus, the combination of therapy means For the parietal technique, that is the dopamine and then mechanical mechanism, and the other is to control the peripheral defocus. So for one, you just simple start atropine. For the last 18 to 20 years, I'm prescribing atropine, low dose, simple make by myself for the patient and working well. Once it doesn't work, then what I do, the combination for the optical defocus, exacto bifocal. Nowadays, the exacto bifocals are not available. So what can you do? You just tell the optician to have a big slab and with the top flat bifocal and make small glass for the child. So that will work more than 90% like exacto bifocal. So these are the two simplest mechanisms. And just start with the atropine and with the bifocal. If the one module is not working, the atropine is not working completely, then start atropine with the bifocal. So this is the simplest way. Effectiveness of the treatment. Now, average levels of myopia control is by soft multifocal contact lens, 40% control in myopia, orthokeratology 50%, exacto bifocal 39 to 51%. So the percentage is very good. And once when it is in combined with the atropine, efficient results. When to modify treatment? According to the clinical algorithm for myopia progression protocol, if the cycloplegic spherical equivalent progression is greater than minus 0.25 diopter over any 6 months, or if the axial length increase is greater than 0.1 millimeter over any 6 months, then you can modify the treatment. If you already start with just atropine, you can add bifocal. There are three pillars for the myopia management: control of the environment, control of the binocular vision, and control of the blur. For example, control the environment. If 20 minutes of continuous use of smartphone increases myopia risk and progression in teenagers, that negative effect can be cancelled if the outdoor exposure is more than 14 hours per week. So take-home message is simple correction of myopia is no longer sufficient. Management of myopia is the standard care. The acknowledgement for the contents and acknowledgement for the research articles. These are the references from where I took all the figures. These are all figures are based on the research. Thank you very much.
Thank you, Professor Mufarik Shah. We'll do the question and answer session at the end of this session if you have any questions for him. Now, the next speaker is Mr. Amir Niazi, who is a clinical optometrist, and he's also working in Rifa International University. Today, he'll be representing Pakistan Optometry Society and will be giving his insights on it. So please join me in welcoming Amir Niazi on the stage.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm not that talented. We have a lot of talent today to shift ourselves to myopia control. And I have 2 and 3 more suggestions at the end to my respective colleagues as well, what we can do. But my agenda for the day, what we can bring to myopia control in Pakistan. So I will skip the figures because there were a lot of figures today in the morning, and we have learned about that the myopia is going to be 50% by 2050. And I would like to have some positive management techniques which can be achieved in Pakistan, inside our clinics. And what we are not gaining, we are able to gain, and we should gain. So let's have a little introduction with the myopia current situation and introduction in Pakistan. We know that it's an alarming sign. We are at risk, a higher risk as compared to the prevalence all over the world is going on. Why it is highly neglected? Because of the traditional optical correction which is going on. Unfortunately, Dr. Zahid is not sitting here. I would love him to be here because he's working with CBM, and we need these people with us. Getting to the school screening programs, it's very good because in rural areas, people do not have a search or opportunities to reach to the refractive levels. We have heard about our respected professor, Dr. Asad Aslam Khan, in the morning. He was saying that we are going to develop the ophthalmic dispensing labs in the district hospitals, and that is a very great initiative. But for me, the concern is that why we are not developing myopia control labs in Pakistan. Do we have not capacity to build these things? Do we not have vendors? Do we not have associations with the organizations? Although government can have some other concerns as well, but what we can do is to have an available opportunity. Dr. Mufarik Shah has told us about the atropine therapy, insightful views from Dr. Adnan as well. Being an optometrist, to be very honest, being an ophthalmologist, more than 90% of the ophthalmologists are not doing the atropine therapy in Pakistan. Why is this so? This is the matter of concern of the day, and this should be the matter of concern to save your generations in future. Why we are not generating? Is it not effective? Is it not safer? If it is not safer, then why we are discussing? And if it is safer, then why we are not conducting the trials? So there is a big gap of research in Pakistan, what should be done. And all these individuals who are sitting here, including me and you, are capable to do that. So we have conventional prescription and we don't have evidence-based myopia management therapies in Pakistan. We do have sources, we do not have sources, that's the other concern. So limited access to specialty lenses, and there is no national guidelines. We all know that we haven't seen a single ad on multimedia or television in our country by the government or any other person to raising the awareness about myopia control. So that makes a question mark, sorry to say. So low parental awareness is further worsening the condition. And if it left unaddressed, the surge in high myopia and associated sight-threatening complication will pose a major public health concern. So that is very much clear to us. So urgent action is needed, and we definitely need to have the myopia control strategies as early as possible. Oh, sorry, going back. And that's the problem in Pakistan, we always go back. I'm skipping this slide. So along with the nutritional deficiencies, limited awareness and access to eye care, the major concern which is contributing to the myopia is urbanization in Pakistan, definitely like some other countries. And what we have got the message through our experience, through our seniors, is the limited access to outdoor activities. That's what we can do, at least our parents can do for their children, to have some excessive outdoor activities as well. If you have no other choices at present at your own host. And some other are the lack of awareness, genetic predisposition factor. In Pakistan, the academic pressure is a big factor where everything goes on multimedias and more than 3 to 4 hours in one activity and then other activity, and the child goes like, sorry to say, like donkey and getting on and on. So we do move to major cities just to have economic opportunities. That's the culture I'm trying to show you in Pakistan, what's happening right now. We have the educational concern. We have better educational facilities in the cities. The healthcare services because we do not have much better services of health in the rural areas, and the technological advancements for that purpose. And this impacts on your poor visual environment, definitely. Having no specific access to outdoor activities due to urbanization. We know that there are no playgrounds, there are no security levels to send the children outside those purposes. And as a result, in a poor lighting condition, in an artificial lighting condition, our children have increased near work activities, and especially after the pandemic of COVID. So what are the challenges ahead? we are facing or we are going to face that. The major, if we talk about the health care infrastructure, limited access in the rural areas for screening. Two, the specialized access to the myopia management in the urban life. That's the major concern. That's the healthcare concern where every should sit and took some initiative for that. Public awareness. People are not ready to listen. Parents have so excuses for us to generate the things that my child is doing only 2.5 hours for screen time and not more than that. And Sir Mufarik Shah had just told that the impact of 2.5 hours of using the mobile, how could the trigger in the myopia we can have? So 2.5 in Pakistan is nothing. So that's the major concern. By hook or crook, we have to teach the parents. We have to tell them that this is the major concern, this is the major risk, and you have to be very serious upon that. Economic barriers, definitely. Everywhere in the world, like other countries, Pakistan is facing the economic barriers. In myopia control, ortho-K lenses are very expensive. We have stylus technologies, we have DIMS, we have HAL technologies, but they are expensive. We are approaching to that, but there is need to sit to have some pure solution. This is what this stage is today for. Then we can go for the educational system. Our educational system needs to sit. We have the whole remedy at the end, which I would love to talk about the healthcare system, educational system, sorry. And to be very sorry to my seniors, I'm also the part of this, and to everyone, we are lacking too much research. There is a big question mark on research on Pakistan, especially. So we need the research. We have to control the students. We have to direct them to go to that, get the figures, what, where, and how, like Adnan said. So we need to these things to figure out, to sort out, and to make the strategies for that particular reason. If we are not going to do that, definitely we are going to face the consequences. Now, what are the available options, and what is the current healthcare structure? To me, somebody can have some other point of concern as well. So there is very limited access to specialized care, myopia care, and I think almost 95% or more than 95%, there is no specific or specialized myopia care in Pakistan right now. So we are trying to search, we are trying to urge the organizations, the NGOs, and the people and the seniors sitting here and everyone to take a look, because the delayed diagnosis, like Mufarik Shah has already told us, that the progression left untreated. So myopia will be lead to more severe, and then that will be the pathological one. And above 5 or 6 is everything okay. Tata bye-bye wali condition ho jayegi aapki. So insufficient awareness among eye care professionals. Being optometrists, being professional, most of the ophthalmologists, the technique, the direction, the criteria is not according to the myopia management. So there's need to create awareness. There should be program to aware. And this is one of the biggest stages right now where we are standing to create awareness. So awareness is the big factor, sorry. Then we have lack of preventive screening programs for myopia control. I'm talking about specifically to the myopia control. There are more screening tools are going in the schools and camps to figure out the data, and we have total data on board. We have maximum data, but the output, we don't have the output. We don't know what the output is that. Resource constraints, we have no vendors in Pakistan. For orthokeratology lenses, we are talking about, and shortly, inshallah, maybe we have 1 or 2 in Pakistan available. So I would love to have NGOs and government sector people please to sit and can take the advantage to address this epidemic in Pakistan, please. So people can't afford spectacle lenses, and if it is up to myopia control lenses, so we know that it starts with 35,000 Pakistani rupees a pair for a child. And I don't think so he or she can carry more than 4 to 6 months. So that's again a big concern, because maybe the father can have the earning of for the whole month can be 35 to 40,000 rupees. Okay. Now, we will talking about the strategies of public awareness campaigns, school-based intervention. This is the key discussion at the end. Encouraging the outdoor activities, regulating the screen time. That is mandatory. That what parents can do. What parents can do to provide them the outdoor activities. Exposure can change vitamin D and other things, and he can have everything at advance. And this time, which he or she will spend outside, that will also be minus from the screen time inside the home. So access to the eye care services and research and data collection. So what is the role of eye care professionals? To us, what we think about that, the role should be number one, early detection and intervention, conduct regular school screening programs. We have requested to school associations in Lahore, we have sat twice with them, and we have requested them to depute an optometrist, at least in your premises. Maybe you have 4 chains or 6 chains or 8 chains, at least one optometrist can be deputed there, because you depute psychologists for their children, or to tell the parents that psychologist is very important. So why not the optometrist is important there to screen out. That can be an early tool to detect to the child to if it is going to be myopic, or if it is really at myopic less than 1 diopter or over 1 diopter. So the management can be planned. So patient education is very important. So they need the advise the patient and children for lifestyle changes, including the screen times and outdoor activities. Management options, we have some solutions. Ortho-K is very shortly coming to Pakistan. That's a good news. And multifocal contact lenses are readily available. We are practicing. They are not that costly, but they should be used. And in spectacles, we have EDOF, defocus lenses, and stylus or Hall technologies, both are available now. Myocon is there, Myopia Junior is there. Bit costly, but definitely that can be taken. So at least we can derive them to address myopia. And the last, atropine eye drops. Yesterday, I requested Sir Amir Chaudhry Saab that atropine is not being practicing, but we should do that. And he told us that not many of the ophthalmologists also practicing this thing. So this should be taken on board seriously by the ophthalmologist, and they should have guidelines. We should be given guidelines how this can be managed in an optometry practice, or how can we proceed with this thing if this is effective. So there's need to get research on these things. And advocacy to collaborate on studies to understand regional trends and solutions. So role of society, that is number one, the parental responsibility. Definitely do not think that 2.5 hours of screen time is good for the child, and over that is not alarming. In Pakistani culture, we do consider the kids with the brother or sister kids, and that's her child uses mobile 6 hours, my child using 2 hours, so I'm superior than that. So this is not the case. Educational institutions should be directed to take the responsibilities, because our children less than 6 years of age, they are going to school. If I'm doing a camp for my publicity, that's another thing. But if the camp or if the screening tool is going to ensure that the myopia is there or not, and if the myopia is there, how could we control that? That will be equally beneficial. And to take the community as an efficient campaigns promoting outdoor activities and regular eye checkups in the community should be given the awareness and community. And these days in clinics, what we are doing, we are trying to fear them. They do not understand. So this is the need of the time. Flan school is giving 4 to 5 hours online work, and Flan's doing that. What we can do, give a solution that can be done within this thing. There is no outdoor activities, there's no proper diet, there is no proper screen timing, and yet we are yelling at the eye care professionals to give us a better solution. That is not possible. Role of the government. So, I'm sorry. Healthcare policies, allocate the resources for nationwide vision screening programs. That's I earlier said. At least Geo can make a 1-minute ad for myopia awareness, or the government should pay that, or public awareness campaign should be done. Infrastructure development. eye care centers should be converted into myopia control centers. That's the idea. That's the dream. What we can do, these things can happen. We cannot afford Stellest lenses. We cannot afford DIMS. We cannot afford Ortho K lenses. But government can do that. But NGOs can do that. See, in the past, we know that CBM has joint ventures. Dr. Mufarik Shah was there at Pakistan Institute of Ophthalmology. I was there 98, far back 98, 2000. I'm not that old that Mufarik Shah do. Please don't consider that. But the things that Sightsavers launched their activities. Then we had Brian Holden Vision Institute working with us, now CBM. So these NGOs can be engaged. They can be engaged well. Do not, if you cannot make it available locally or in the market to get business, being an NGO, being a trustee, you can attach the association with the government. That's why we were dispensing the low vision devices in the centers for free of cost. Why not to have myopia control programs, and we can provide these things to the children? These things can happen. Serious notes should be taken on these things. And last but not the least, the subsidized treatment provide affordable access to the advanced myopia control therapies. So again, thank you very much. These were the 5 factors. But capacity building for the eye care professional, that's the keynote. That's the home takeaway message. Strengthen the healthcare infrastructures, collaborate with the school organization, and deploy the optometrists there. That's the need of the time. Do talk. I'm not a government person. I cannot talk to the government, but I can talk to the private associations as well. So we can, being the societies of optometrists, we should work with that, collaborate with the government and public aware campaigns. So that's all from my side. Thank you very much.
Thank you, Amir, for providing us overview of Pakistan Optometry Society. Now, our last speaker for today's session is Dr. Monica Jong, who will be joining us virtually as the Global Director of Professional Education Strategy for Myopia. Dr. Jong leads impactful initiatives to enhance disease awareness, advocate for patient care, and advance evidence-based practices. Her expertise spans functional team leadership, education development, translational research, stakeholder engagement, and medical affairs. Please join me in welcoming Dr. Monica with us online.
Hello, everybody. My name is Dr. Monica Yong, and I am the Global Professional Education Director of Myopia at Johnson & Johnson Vision. And I'm also an adjunct senior lecturer at the UNSW School of Optometry and Vision Sciences. It's a pleasure to be here today to talk about a few different myopia management cases. Now, these cases are just for illustrating how to do myopia management. So please use your clinical judgment when you are assessing your own patients. And here are my disclosures. I am an employee of Johnson & Johnson. And the advice here is not a substitute for your own medical training and adjustment. Myopia is one of the greatest eye health threats of the 21st century. By 2050, the prevalence of myopia will reach 50%, and almost 5 billion people will have myopia based on current trends. And this isn't even accounting for the 3 times increase in myopia that was reported in China during the COVID lockdowns. Today, professional associations such as the World Council of Optometry, the American Academy of Optometry, and the American Academy of Ophthalmology recognize that myopia management should be the standard of care. Practitioners today have the ability to provide patients with a treatment option matched to the patient's clinical and lifestyle factors. Today, I'll be sharing a variety of case studies to show you which will help how you can treat myopia so that you too can be part of combating this myopia epidemic among our children. We now come to our first case, Mathis. Mathis is a Eurasian boy who is 6 years old, and it's the first time he's visited the optometry practice. And he has no complaints. His parents are bringing him for a routine check today before he starts school next week. Now, what would you do? We would conduct a comprehensive eye examination. So we'd go through and do all the initial eye examination tests, such as the baseline uncorrected vision, as well as measure best correct acuities, do a refraction, and then a cycloplegic refraction, as well as check the ocular health of the eyes. We can also incorporate measuring axial length, as well as doing corneal topography to look at the corneal map and check the case. Upon careful questioning, however, when we ask him in more detail about his distance vision, he mentions that sometimes his vision is blurry and he squints from time to time. Other information you can also find from a detailed history points towards some other risk factors. He is less than 10 years old. That means that he may be more sensitive to developing myopia. He has two parents with myopia, one that's highly myopic, so we know that that's already an increased risk of myopia, having parents that have myopia, and especially when one of them has high myopia. His sibling is 4 years old and is not yet myopic. And Mathis goes outside a very small amount of time a day, so only 30 minutes per day. And we know that increased time outdoors is definitely better for vision development, and more than 2 hours per day is able to halve the number of new cases of myopia and even slow axial elongation somewhat. Now, Mathis also really enjoys mirror work. He likes reading books and averages about 3 to 4 hours on iPads and books combined per day, which is really a huge amount. The parents are really hoping that he won't have myopia, given that they already are myopes. They understand what it means. So take the time to examine Mathis and explain and educate, because it will save you more time in the long run, as well as build up the likelihood of success in having the parents on board with whatever management suggestion that you make. On measuring Mathis's vision, you find that his uncorrected vision is reduced. His right eye is 618 and his left eye is 69. And when you do a refraction, you can see that he is showing up with myopia and some astigmatism, but he does correct to 20/20 with both eyes, or 6/6. His binocular function is normal, and you can see that his subjective refraction is a little bit less than what comes up on autorefraction, because we know that with autorefraction without cycloplegia, you can end up over-minusing. After the initial visit, we decide to bring him back the following week for the further testing, which includes the cycloplegic refraction, topography, as well as measuring axial length biometry. And the reason for this is because for some children who are very young, having them sit for such a long length of time is not really feasible. So the cycloplegic refraction reveals slightly less myopia than what the subjective refraction was. And then topography also showed normal corneal profile. And we also measured photopic pupil diameter to be 4.5 millimeters in each eye. And the reason we measure that pupil diameter is because if we're going to go and do any kind of ortho-K or consideration of that, it's good to know what the pupil diameter is. The axial length is 23.5 millimeters in the right eye and 23.75 millimeters in the left eye. And it's important to have the initial measurement so that we can monitor the axial length change over time, especially if we do implement myopia management. So what would you be thinking of now? What do you feel you would do to manage the child's myopia? So there's been a number of axial length growth charts that have been published in the literature that are available, and some axial length biometry devices also have their own normative database. So it means that when you measure your axial length at the initial visit or baseline, it can be plotted against these and monitored over time. So looking at where Mathis's axial length is sitting on an evidence-based myopia growth chart from Tiedemann et al., based on European children, it shows that the risk of Mathis developing high myopia is about 9%. And that's because he sits around, just around here on this line. So he's He's about 6 years old. He's already 23.5, so he'd be about here on the chart. Given his young age, this is quite serious, that he's already close to about minus 0.75 in the right eye with astigmatism of minus 0.75 as well. So we need to start thinking of myopia control immediately to help really reduce the risk of Mathis increasing significantly in myopia to reach the levels of high myopia. It's highly likely because every year at his age, he may continue to progress at least 1 diopters until he reaches the age of 10. And that adds up very quickly. So we also need to provide counselling and education on the lifestyle risk factors, such as the need to be spending more time outdoors, at least more than 2 hours per day, as well as reducing the amount of time spent on near tasks such as the iPad and reading. And that's because we do know that intense near work is associated with increasing the risk of myopia progression. Now, in terms of going through myopia control options, this does take time too. So you can take into account his full lifestyle and what the parents are interested in terms of the management options and what the child is also capable of. So looking at his age, is he able to handle contact lenses, soft contact lenses? That's an option. Are the parents willing to be part of the process? If they are, there's also the option of orthokeratology so that they can insert and remove the lenses at nighttime that reshape his eyes so that during the daytime there's no need for any refractive correction. Is the child very active? Does he like swimming? Does he like sports? Those things can also guide you as to whether or not they're capable of or they need contact lenses. So if a child is capable of washing their face, brushing their teeth themselves and dressing themselves, then yes, soft contact lenses are a possibility. There's also myopia management spectacles, depending where you're located. They're also very useful as a first line treatment because they are easy to use. Parents also understand how spectacles work. And then there's also the drug treatment options as well. But that involves parent being part of the process of putting the drops in, such as low-dose atropine, 1 drop in each eye overnight. So after carefully going through the options with Mathis and his parents, it was decided that myopia management spectacles would be the best or the most appropriate treatment for Mathis at this point in his life. So Mathis has been attending the office every 6 months for review, having his vision measured, subjective refraction, as well as axial length monitoring. And here are the results of 1 year later. So he's now 7 years old. He's been wearing his myopia management glasses for 1 year. And upon querying, we are finding that there is overall good compliance with the wear, which is important for the treatment to actually work. Mathis and his parents are saying that Mathis is wearing the glasses about 8 hours a day. However, he's also removing them quite a bit. For instance, not wearing them at home. He doesn't wear them to play sport. And he actually doesn't wear them when he's doing his close work because he feels he can read very well. So in fact, he may not even be wearing them 8 hours a day as they believe. And we also find that the prescription of his current spectacles has gone up a lot from minus 1.25, from minus 0.75 to now minus 1.25. So it's gone up about 0.5 diopters and 0.75 diopters in the right and left eye respectively. And the axial lengths have also increased. So we're seeing that the management is not really as good as we would like it to be. So should we be concerned? Here is a table that's available for different children based on their age and their ethnicity. Either they're Asian or they're white. That's all we have in this table to compare from. But it shows you the average axial length change and the average refractive error change if they're just wearing single vision specs. So this allows you to monitor the change in the measurement every year to compare. So we should be looking at 1 year change to see if things are working because there is seasonal differences in myopia progression. We should monitor the kids at least every 6 months, but make a decision by 1 year if a treatment is working or not. And if it's not working, you have to try to understand why. How's the child using the treatment? Are they using it correctly? But research shows that untreated kids who progress to myopia will show an increase in both axial length and refractive error. So doing something is definitely better than nothing. All studies demonstrate that myopia management options have the greatest treatment effect in the first year. There is effect that continues on over time, but the effect is a little less over time. Now, the expected axial length change for emmetropic eye growth, as you can see from the graph, is shown. At age 7, expect about 0.18 millimeters axial length change, that is just normal eye growth. And then in our case, Mathis's axial length change is more than expected at 0.2 millimeters in the right eye and 0.26 millimeters in the left eye. Clearly, Mathis is still progressing, so we need to provide counselling on lifestyle and improve compliance. So if a child is progressing more than 050 diopters in a year with myopia management, I know not everybody has an axial length biometer, so you can still use refraction as long as it's an accurate refraction. Then you can still do myopia management. You don't need to have an axial length biometer to do it. Now, we measure axial length because axial length is the direct measure of eye growth, and it is the excessive axial elongation that's linked to the increased risk of vision impairment in the long term. But we know that every diopter matters according to Bullimore and Brenner. So given that Mathis is still progressing, we counsel him on the lifestyle, and we also do remind him that he needs to keep his glasses on. But speaking to his parents, they do want him to actually use his treatment. So together we decide to switch to soft daily disposable myopia management contact lenses in a silicone hydrogel Oasis material to help improve the compliance and to see whether we can get him to wear a full day of wear of the soft contact lenses and even up to 7 days a week. And then when he's not wearing his contact lenses at home, he can put on his myopia management spectacles. So consider switching the strategy if the target isn't met, so they're progressing more than 050 diopters a year, the patient isn't compliant, and we can also take into account their cost and budget issues. We keep following Mathis up every 6 months, and he seems to really like wearing the contact lenses because of the lifestyle benefits. He's a very active child. He's going out more outdoors now. And 2 years later, we collect additional results, and he's wearing the ring focus soft contact lenses for myopia management. This technology has been published in Ophthalmology Science, and it is a technology from Johnson & Johnson that's only available in select regions in the world. And he's been wearing these lenses for 1 year. So his current prescription is about minus 150 diopters with a stig of -1 in the right eye, and in the left eye, the myopia is about minus 150 diopters with a stig of minus 0.75 diopters. So compared to 1 year ago, it's an increase of 0.25 diopters in each eye, which is very, very acceptable, demonstrating that there is treatment success. And his axial length has increased only slightly, which is 0.08 millimeters in the right and the left eye. And this is actually less than the emmetropic eye growth that we demonstrated from the previous charts. So this is a great case example where we've been able to optimize our management to produce a superior myopia management effect. Another thing to also think about is how long we'll be staying in management for. We'll continue to monitor Mathis in this modality over a number of years, and it is an education to the parents, mentioning that myopia management could be into the child's young adulthood, because they'll still be studying and they'll be in university, probably into the age of 21, so they may still be wearing those contact lenses up to 18 to 21 years old. And we may even move into something else if there's new technology that changes or his lifestyle changes. And we do know that half of children continue to progress in myopia after the age of 16. So we do have to continue to monitor children in myopia management in the long term and do so objectively, as well as following them up and checking their eye health. So thank you very much for your time, and I hope you really enjoyed this discussion about a patient case in myopia management. Thank you so much.
We are very thankful to Monica for putting in the effort and sending us her talk. She couldn't be with us online due to her difference in time zone and other commitments, but I'm going to open the house for other speakers. If anyone from audience has got any questions for any of the speakers, please let us know. I think everyone wants to call it a day. So if there are no questions, I would like to thank all the speakers for their valuable insights and time. And also a special thanks to co-chair and chair of today's scientific session too. To conclude this session, I would welcome the chair of the session, Professor James Wolfson, to just come on the stage and conclude with his remarks. Thank you.
Thank you again to the University of Faisalabad for organising this fantastic third Myopia conference. I hope you all feel that you've gained something from today, whether that's networking with other colleagues, whether that's the inspiration about hearing about all that you can do as a professional. But one thing I'd like you to all do is make sure you take something away from today. Take something that will change your practice, because that's what makes a real difference to our patients and our population. So thank you again for engaging in this event and to the organisers.
All right. Now, the last bit of the conference. On behalf of the scientific committee, I'm very thankful to all the participants who have submitted their abstracts to present orally and in the form of posters. Posters are still there in the stall area if you guys would like to have a look at them. But I'm going to make a very special announcement for the best oral presentation, which was judged by our chief guest, which is Professor James Wolfson, and other esteemed guests. So to first present, may I call the best oral presenter. The topic of the presentation was efficacy of atropine eye drops on axial length in myopic patients. And this was, the abstract was submitted by Mr. Basharat Ali, supervised by Ms. Aisha Kiran. So please, a huge round of applause for the presenter. To give this award, I would like to welcome the chair of the session, Professor James Wolfson, Ms. Aisha Salim, and our esteemed Professor Dr. Amir Ali Saab to please come on stage and give this award. जी सर सर ये बस आ रहा है नोट आ रहा है We have another winner. Congratulations, Aisha. Congratulations, Basharat Ali. जी sir, एक और है. Now this one goes to the most enthusiastic part of the team, who are our undergraduate students. They have done really well. They have worked really hard, and the submitted poster, all the posters were wonderful. The best poster award is given to the abstract effect of central zone diameter on visual acuity in myopic patients. And to get the award, I would request Ms. Iman Fatma and her supervisor as well to come and join the award. Thank you so much. Congratulations, ladies. I also want to thank all of you for your participation and engagement today. And we look forward to very insightful sessions in the near future. Let us carry forward the knowledge showed today and continue to collaborate in our efforts to enhance eye care. Thank you once again. To formally conclude the session, may I request all the speakers to come on stage and have a group photo with Amir Saab, sir. Sorry, you left a bit early. So the students are directed to go to the stalls area where they will view the posters first. So, no, I think, sir, you should announce it. So there's a very special announcement which we would like to make today, and I would request Professor Amir Saab to do it personally.
So the program or the date of next conference, inshallah, a big inshallah, will be inshallah on March 2027. Thank you. Fourth International Myopia Conference.
Thank you, sir. Thank you, sir. Can I request all the speakers to please come on stage for a group photo? Speakers from yesterday's oral presentation can also join. And maybe members of our organizing committee, this is a good chance for you to come in.
All students are requested to direct you towards lab for the lunch.